حياكم الله في اليوم الثاني First Pediatric International Conference, and we'll start the session today with our distinguished speaker, Dr. Amal Al-Awami, Developmental Behavior Pediatrician, Pediatric Residency Program Director at Johns Hopkins, Aramco, Saudi Arabia. Dr. Al-Awami obtained her Bachelor of Medicine from King Faisal University. Then she pursued her career development by completing her pediatric residency program from Baylor College of Medicine, Houston, Texas, United States, and leadership education in neurodevelopment and related disability from UMass Medical School, Worcester, United States, followed by fellowship in developmental behavior pediatric from Taft Medical Center, Boston, United States. Dr. Amal is an active speaker, and she has participated in a lot of conferences and awareness campaigns. Welcome, Dr. Amal, to this.
Assalamu alaikum, sabah al-khair jami'an. Thank you for the invitation to be part of this beautiful and really fruitful kind of conference. So thank you everybody who wake up early and came to the conference as early as 8:30. Thank you so much. So today we're going to be talking about media and electronic effect on the development and behavior of children. So bear with me, I'm going to dissect every part of the development and how the electronics can have a positive or negative effect. So I have nothing to disclose, and I always joke, although I wish to, but I have nothing to disclose at this time. And the outline, we're going to be talking about the American Academy of Pediatrics recommendation for screen use in children and the effect of media on, as I said, on different level of development, like the health, brain development, language delay, ADHD, and violence. And at the end, I'm going to be talking about also problematic internet use. And is there a virtual autism, which if you really follow the social media, you see a lot of debates about this terminology, and we're going to dissect that, inshallah, at the end of my talk. And eventually, we'll talk about take-home messages. So I will start with some definitions. I think there is a lot of media and electronic use, but there are like several different ways that we are exposed to electronics. So the broadcast media, which is the TV, Netflix, YouTube, this is like directed to everybody and everybody can watch them. And there is more interactive media like chatting and video games, either offline or online, and eventually the artificial intelligence that's coming very fast and very, I would say, strong into our field. And you could see that this conference is alluding to the effect of the artificial media and how it helps. But of course, the artificial media can be in different aspects like ChatGPT or Bard or any other stuff. And the social media, and the list is growing, by the way. I sat with my children to make sure that I cover the most important social medias. Of course, WhatsApp, X, Facebook, Instagram, Snapchat, TikTok, Discord, Reddit, and trust me, the more we know about these social media, these kids will create another platform that they are using, and they are secretly chatting with each other and transforming information with each other. So what is the American Academy of Pediatrics recommendation for the screen use? It says from 0 to 18 months, see that, no screen. And I'm sure all of us have seen a 9 months old and a 12 months old holding a handheld device, right? So it says no screen. It's okay to do video chat because there is more social interaction. For the 18 and 24 months, it says parents should be aware and be present, and high quality kind of screens or videos or games or whatever it is. But you have to be present with the child. From 2 to 5 years, it says only up to 1 hour, and high quality, and family has to be present. So you see how strict the American Academy into it, and we will know why now in this slide, the coming slides. How about more than 6 years? Now, the American Academy knows that the schools nowadays is asking the kids to be on the iPad and laptop to create some kind of projects and so on. So it left it to the parents to decide how many hours of screen time is allowed. But see the comments. It says there are criteria for things to be done. No screen at meal time. And I'm sure a lot of you know that some of the parents put the kids on the screen to eat. So no screen at mealtime, no screen 1 hour before bedtime, no devices in the bedroom, and of course, if you finish all your physical activity, you do your homework, you do everything else, then whatever left over is okay for the screen. You see, I mean, if you count the hours, it will not be more than 2 hours a day. But of course, you have to prioritize. Not we gonna be on the video games for 6 hours and then do homework. So that's the difference. And of course, we have to always have a screen-savvy kind of talk with our children and cybersecurity and how to be nice to others also online. Okay, so that's the American Academy recommendation. I would just remind you, it's always puzzling to me, that the internet made available for everybody since 1991. But the health device, or the iPhone, was there only 2007. So for us, as a pediatrician, all the pediatric age group now, they were born after that period, right? So if you calculate, they're born in 2010. So all of them does not know life without a mobile. So that's puzzling. For us, we don't understand that, because we will using the phone and then even Motorola that was there and so on. But now nobody knows the life without an iPhone. So put that in your mind, the way you approach the children and how they are attached to it. All right, so general information. Children, preteens, 10 to 13, they spend around 4 hours per day. That's statistics, huh? Youth, which is 13 to 18, they spend around 7 hours a day. Now, children spending more than 35 hours a week of screen time face a higher level of metabolic syndrome. And we see a lot of obesity, and we talked about the diabetes, how it is very prevalent in our country. And usually girls, they want to be more accepted, so that they are in the social media more, but the boys usually like to be fit and competitive. That's why they like the video games more, but that's not a solid rule, but that's the usual through the studies. Now, what is the effect on general health? I'm going to go over it quickly before I go to the development. First of all, there is an increase in the past 50 years of myopia. We don't know the reason. Could it be the screen? We don't know, but that's something to put in mind. But there is something called computer vision syndrome. Dry eyes, irritated, blurred vision, some headache, some muscle ache, and that can be related to long hours of being on the screen. And that's not only for children, for us as adults, yeah? So we need to use different ways of resources to read, and we're going to talk about 20-20-20 rule and avoid reflection, dim the light, good posture, and so on. So what is 20-20-20 rules? It is every 20 minutes, you need to look away for 20 seconds, at least away by 20 feet. So for us also, if you really follow that, you will have a better adjustment of your lens, so you look away a little bit for a while and then go back to your screen. How about the posture? We always like a turtle on top of our mobiles and our laptop, but it's better to always think about the right posture, how to put your shoulder and back, and that's for everybody, obviously. Now, the effect on fine motor. Remember, these children are spending a lot of hours using their fingers, right? Or the whatever they're playing with. So there is a decrease in the skills of these children in fine motor. So, and who tells us that? It's the preschool teachers, it's the daycare teachers, that they're saying that these kids take them a long time to learn how to do scissors. Pincer grip is very difficult, so that's why our OT is really working hard with these children. And of course, writing and handwriting is disaster. Well, for us as doctors, we know and understand, and all of us have the same thing. But for children, even cursive, they removed it, because really it's hard for children to do the handwriting the right way. And is it because of the electronics? We don't know, but that's the statistics again. How about the effect on sleep? Chronic sleep disorder is very known, and usually it causes eventually metabolic disease and memory loss. So is it related to electronics? Possibly, a lot of possibility there. And really the decreased sleep duration and also sleep disturbance due to night messages if you keep your telephone on, what we can do about it is please mobile outside bedroom, and this is, or put it in airplane mode so nobody really can bother you at night. And how about delays in the initiation of sleep? People have insomnias, right? Because sometimes of the content, so you keep on thinking about it, especially if you read bad news or something, and the blue light makes you feel that it's the daytime, it's not nighttime, because it affects your melatonin. And of course, biological circadian rhythm is affected. And really what we need to do, no screen at least for 1 hour prior to go into bed, and dimming the screen onto a night mode. So check your mobile. There is a night mode that can help you really relax when you're reading at night. So media and obesity, we talked about how, there is an increase in metabolic rate and metabolic syndrome, and obesity. So there is a direct relationship between hours of use of electronics and obesity and BMI, either increased sedentary time, eating more while watching all of these advertising, McDonald's, Galaxy, and all of these food, because you say, oh, I feel like I want to eat now, although you're not hungry. TV in bedroom, obviously, it's really associated with obesity directly, and of course, watching more time, obviously, will increase the obesity at least by 10 to 27%. So what is the effect now on brain development? Here comes to my field now. First of all, I like this diagram, and I always like to talk about it. From birth, or even before birth, till 2 years of age, you could see how synapses formation is huge. By 2 years, you reach your peak of synapses in your brain. And eventually, all the synapses or connections that's not used, what the brain does is pruning. It cuts them down. They don't need them. So you could imagine what happens if you're from 9 months, 6 months to 2 years, all what you do is visual, auditory kind of stimulation that will eat up from your social communication connection. And eventually all what you know is using the electronics, and you don't know how to interact rightfully with others, and that's where the problem happens with the development and interaction with others. So, and of course, and if you prone these, it is hard to reform them, but that's what the early intervention is really all about. How about the neurochemical changes? We talked about decreased melatonin and increased dopamine, acetylcholine, and all of the others, I will say neurotransmitters, and abnormal circadian rhythm can happen, and that increase also chance of depression and psychosis, and that is well studied also. The effect of media on the brain, if it is more than 2 hours a day for teens and preteens, it lower language development. How many of you talk to a 10 years old and you want them to tell you an event and they're talking gibberish? They cannot really tell the sequence of talk. They cannot give you the right terminologies and descriptions. And they're talking as if the language is not their language. Because the language development needs interaction. It's not only playing Minecraft and Roblox. That will not teach you anything, really. Anyhow, so it lowered the language development, lower cognitive development, and eventually, if it's an excessive use, more than seven hours, even MRI showed thinning of the cortex. And that's really worrisome, حقيقة. And it lowers eventually the academic performance. So when is it problematic? I'm sure all of you said, well, we see our kids doing that, but are they really having a problem use? Are they addicted, yeah? So overthinking, so when it is problematic, if the child or the person is overthinking about the use. When am I going to go back to my social media? When am I going to go answer the Twitter message? When am I going to go and continue my games and reach a different level? So it's overthinking about it that taking away other activities. It starts to affect the functionality. They're not doing well at school. They're not going out with their friends. They're not playing sport or exercising. So that's a function of the children, right? So if it's eating up from what is they need to do, then it's becoming a problematic use. And of course, any presence of psychosis, nobody will question it. It's a real problem. So the electronics and use and the addiction, it comes in three major categories. We're not going to talk about them because that's not the major talk today. But problematic internet use, there is internet gaming disorder, and there is fear of missing out, which is FOMO. And usually that's in the social media in particular. And especially when they see others are having fun or having even conference, and it's like, oh, I wish I could be in that conference. It looks so appealing. But they feel that they missed. But that's a good missing information. All right. So problematic internet use, watching social media, abnormal dopamine, because dopamine is for addiction. Remember that, yeah? The more dopamine you have, the more you want out of that. That's why when you exercise, you have high dopamine, you want to exercise more, and that's a good one. But also with the social media, there is a surge of dopamine whenever somebody press and like or retweet or something like that. So abnormal dopamine level, addiction and urge to use, stressed when needs you stop using, and of course there is an increase in the use, and we go into the vicious cycle. Obviously, there is high association with mood disorder and ADHD, and the treatment usually for it is what do you do for an anxiety, which CBT and SSRI. What is the effect now on development? Let's go for the effect on language. So exposure of 15 to 35 months old children to at least 135 minutes, which is 2 hours and a quarter of screen every day, there is a language delay at least 3 times, okay? That's comparison to only 16 minutes a day. And if their children is less than 1 year, with increased screen time of more than 2 hours, there is a language delay of at least 6 times the normal. So that's a big, huge language delay disorder that we're facing. And I'm sure that a lot of us is accepting children not talking at the right time, saying, well, it's okay. 2 years saying only 1 to 2 words, it's okay. That's not okay. This child is delayed. How about, is the effect really only through being on the screen, or the effect is because we're not interacting with parents? And not only that, it's not me only being on the screen as a child, it's my parents who are on the screen most of the time and not interacting with me. And that adds up another layer to the problem, really. All right, so for each hour of screen time increase in children, there is a loss of 500 to 1,000 word exposure. Can you imagine that number? It is a big loss for these children, and that really affects them. Other studies says even the language delay is 6 times, not only 3 times. 6 and 8, actually. So 3 hours or less, language delay and attention, and that's the effect now on ADHD. More than 3 hours, not only this language delay and attention, also hyperactivity, but it does not mean it causes a disorder. It causes symptoms of ADHD, but it does not reach a disorder. That's a very important bottom line that you will come out with. So being on screen, gaming or playing does not cause a disorder, but it causes symptoms common or related to inattention and hyperactivity, and we could talk about it later if you want to ask more. What about aggression? A lot of kids saying that a lot of parents, saying that our kids, whenever they are playing on the screen, they become irritated, they scream, they push their siblings, they are hard to come off. Is that an aggression? Are they going to be more aggressive? And the study says that at least for 3 hours after being on a screen that's full of aggression, the child is aggressive, but that goes away after 3 hours. Now thinking about it, if the child is away from the screen only to eat meal and go back, then when it's time for them to wind down and go back to normal behavior. So that's a problematic. So it doesn't really cause aggression per se, but increases the anger burst and irritability overall. So does the screen time now causes autism? Coming to the virtual autism terminology. More screen time, there is chemical changes, we agree on that, and there is some autistic traits, which means some stereotypy, like flapping and jumping, decrease in cognition, like they don't know really what's going on around them and how to problem solve, and there is a language delay. Now, this study, just talking about more screen time, there is an increase in visual auditory connection, as I mentioned, in over the use of social connections. And this term, virtual autism, has been emerged in the 2018 by somebody called Maris Zamfer, who's just a psychologist. And the study was done on orphans in Romania. And we're going to talk about a little bit because it's important for us to understand.
3 minutes.
لا 3 minutes هذا ما بنخلص اليوم. إن شاء الله. Okay. So this study was done by Dr. Nader Rahili here in Saudi Arabia, over 300 children almost, and really their conclusion was that the more screen time, there will be an autism traits or autism symptoms, but I think they meant there is no autism disorder. And we'll talk about this terminology in a few minutes. There is no scientific terminology called virtual autism, either in DSM or ICD. First established, as I mentioned, 2018. The study based on Romanian orphans. So can you imagine what orphan does in the orphanage? I mean, they're all having one, maybe 10 of them having one caregiver. They are on the screen. We don't know what is the situation, why they are in the orphanage, who are their parents, and how is the interaction. Obviously, they will have symptoms of developmental delay. That's a must. But is it the screen that's caused the autism? I think the connection is not very valid there. Anyhow, so as I mentioned, and he mentioned, the Zamfer, that these symptoms disappear whenever the child is off the screen. So we'll talk about it. So what is wrong with using this terminology? Why am I against it? Why am the scientific community is against it? It's misleading, and it causes delay in the early intervention. And I've seen that, honestly. It's like, oh, don't worry, just stop the screen and it will go away and you're fine. And 1 year after, this child is still having autism, right? So it's not only a simple terminology. I think it does causes a delay in the diagnosis, delay in the intervention. So as I said, children with developmental disorder spend more time, and it's well known because it's very repetitive and they like that. And of course that will increase in the screen time, decrease in the language, decrease in the social development, and we go again and again. I don't have language, I don't have skill, I will watch TV or play games and so on. So the summary, being on the screen is bad, we know that, and it needs to be monitored, but it does not cause autism. Autism is a neurodevelopmental disorder, 80% is inherited, and being on the screen does not cause it. And of course, all children with autism or without autism, honestly, will improve if you remove them from the screen. So that does not diagnose it or take it out. So bottom line, each child with social skills delay, with repetitive movements, with restricted interest need to be fully evaluated for autism, and we don't really rely on only being on the screen. Autism is autism spectrum disorder, and there is no place for visual autism, and we really don't know the real extent of the effect of the screen and games on children. All what we need to do is to stick to our own recommendation for parents about it. Lastly, what is the positive note about electronics? They're not only bad, right? I wanted to make my talk is like good, bad, and evil, but anyhow, I changed the title for my lecture. So they have better reflexes, better visual motor integration, better spatial orientation, better skills in reading pictures and graphics because it's all visual. Some active programs that promote some physical activities, although they lie about it. I've seen people playing tennis like this just to move the stick. It's not like really playing tennis. And better search and finding information. And it is the future, and we have to admit that. That will be my last slide. We will need to learn the facts. The electronic and social media are here to stay. They will not go away, yeah? And we need to learn how to monitor ourselves and our children, or how many times we spend on the screen. We should not let small children having a free access to screens, and limit the time of older children spending on the screen, find more attractive alternatives, which is a must, and having a home plan. And that is a website. I really recommend that everybody download it. You could go and find a plan for your family. I had it for one of my kids. It's AlAwami Family Media Plan. Did we stick to it? I tried my best, but now she's older and she laughs about it. All right, so these are my resources. Thank you so much. I think we will leave the question to
Yeah, the discussion will be after the second presentation.
Thank you, Dr. Amal, for this nice presentation. I'm sure most of us who had kids did try to think what we're doing at home. We'll continue our session. We'll take the questions at the end of the morning session. Our next presenter is Dr. Ali Al-Assad. He's a medical director at King Fahd Hospital in AlHasa. Dr. Ali is a highly skilled psychologist with subspecialty in adolescent and child psychology. He completed his fellowship in Child and Adolescent Psychiatry Fellowship in McMaster in Ontario, Canada. He was involved in unique research and publication. One of his publications is psychosocial aspect of thalassemia and family quality of life. I'm very glad to introduce him. Please welcome Dr. Ali.
Assalamu alaikum. Thank you for inviting me in this conference, and I think I'm gonna carry on from what Dr. Amal said and move on to the second generation, with the second, like the adolescents and social media use. So there is nothing to disclose. Interestingly, in different books, they define adolescence in different ways, but they mostly start the definition with the biological definition, which is the puberty, and then the end of adolescence, they talk about the social/psychological definition, which is the achievement of self-sufficiency. So it starts with the puberty and ends with the achievement of self-sufficiency. So adolescence is characterized by many things, but there is increase in emotionality. So there is a challenge with emotion regulation, sensitivity to peer social interactions, greater reward seeking, and engagement with long-term and social complex goals. Now, with great skills comes great vulnerability. So they are more emotional and they will have behavioral dysregulations. Another aspect to keep in mind is in adolescent, they are the centers for reward sensitivity develop in the brain. However, there is a lag in the regulations of these centers. So this regulation takes time, up to the age of 25, for them to develop it completely. So there are different theories in development. I'm going to talk about them, and then I'm going to talk about some social media theories. But here I'm going to talk about two of the main things, which is the first one is Piaget's 4 stages of cognitive development, and I'm going to focus on the fourth one, which is the stage of formal operation that starts in the age of 11 years old and beyond. And here, when we talk about formal operational stage, we talk about the stage where the adolescents start to develop deductive reasoning, where they can use their mental actions and perform it depending on the ideas, on the propositions. So they can they can use hypotheses in when they think about anything that they read or talk about. So this is a plus, and it has its challenging sides. So they can, as I said, think abstractly. They can use deductive reasoning. they can work through dynamic systems and interact with others in more efficient ways. They can imagine the points of view of others, so they are more empathic. They could understand others better. So the implication of this is that it helps them to form a stable identity, okay? And by understanding others people's, they are more to understand other people's perspective, as I said, and they are more empathic. They are more able to make more difficult decisions than younger kids. Now, the challenge with this is that what we see with people with anxiety, and maybe this is one of the reasons why we see generalized anxiety disorders in teens rather than younger kids, is that they could, with having this skill about abstract thinking, with having theories about things and thinking about what's beyond what is there regarding facts, that they could be more, they could ruminate more, they could be more anxious, they could be more depressed. Because they are not taking like younger children. Younger children only see facts. 1 + 1 is 2. But in adolescence, they see what's beyond the facts. So taking other perspective also might make them more sensitive, more vulnerable to other people's experience, and then they themselves experience distress. Another thing is the egocentrism, which might be affecting them while using social media, is that they are self-conscious and they think that people are going to think about them all the time, and as they are thinking about themselves. The other theorist that I'm going to talk about is Erikson's psychosocial stages of development, and the fifth one is the one that we're going to talk about, which is identity versus identity confusion, because again, this happens in the adolescence stage. The challenge is to develop a lasting integrated sense of self. In this stage, they try to overcome uncertainty and to become more self-aware about their strengths, their weaknesses, become more confident about their own qualities. So they have to go in this crisis, basically, and questioning their values, their ideas, their future occupations, and their identity. And the challenge here that we're facing in this era is the sexual identity, because of all the propaganda about the LGBTQ whatever community and others. So this is one of the biggest challenges that adolescents are going through. So in this process, they self-reflect, they go back to check their self-definitions and trying to arrive into a stable identity. And this doesn't only happen by themselves, just thinking and looking. It happens with the interactions with others, with peers, with caregivers. And so they tend to explore the environment, to explore in reality or in virtual reality, and then introspect. They take what's out there and challenge their own values and other things while questioning them, and try to gain their own, to make it their own ideas, their own perspectives. So adolescents use digital media for many reasons: communication, information, entertainment, becoming popular, with peer interactions, and in many ways. A study was done in 2018 and another one in 2019. Again, it spoke about the 7-hour use, that most of them were using the digital media in general for more than 7 hours, and that's excluding school time. Yeah, that's excluding school time. So this 7 hour was just for leisure. And the one that was mostly used was YouTube, then then Instagram, then Snapchat. And again, there are many platforms that are out there. From that time till this time, for sure, things have changed and more platforms are being used. Around 50% were 11 years old when they started using social media. And again, an interesting thing is most of social media apps, if you read, and nobody reads the terms and conditions, is that you're going to see that I read it because I'm making an app. So I read for Twitter, for X, for Snapchat, for WhatsApp, all of them, they say you have to be 13 years old and above to use the application. But everybody's using them, even now, even younger generations, they are using them. Most of the apps are from 13 years old. And as we see in this study, 50% were 11 years old. So social media could be a playground, could be a place where they could interact with other peoples, and this will help the teenager form their identity and explore more and form their identity. However, exploration should be done in a safe place. And in real life, when the interaction ends, mostly things end when the adolescent leaves, and most of the time it's not carried on. The challenge with social media, people go back and tell you, well, this happened 10 years ago, 5 years ago, and we see it even with different people. Like people go back and dig for them and say, oh, you said this 2 years ago, 3 years ago. So whatever is there, it's not safe. If somebody posted a picture of them, let's say an inappropriate picture, it's there for life. It's not like before when it was a safe place. So deficit in the stage of identity versus identity confusion, if the adolescent failed to pass this stage, they were going to have more low self-esteem, indecisiveness, anxiety, uncertainty. Their sense of self will be disturbed. They're going to have problems in the next stages, which involve intimate relationships, social rules, and others. So, and also this will increase the risk of internet addictions because they're going to be looking for things to improve their self-concepts. So some of the social media theories that I found interesting, the selectivity paradigm, which means that you as an individual or the adolescent as an individual is going to seek certain media messages. I'm going to go on Twitter and look at certain hashtags, certain things. And in response to that, I'm going to be influenced by what I sought from the beginning. So I was looking for example, let's say autism and vaccination. And I'm looking for a certain information there. I'm going to have more information and I'm going to confirm, which is a confirmation bias, what I'm looking for. In teenagers, it's the same thing. The second thing is the transactionality paradigm, which is that as a media user, the adolescent is the starting, or the adult is the starting point. Okay, so you're going to use the media, choose what you want to see, then this media is going to have effect on you. And by this effect, you're going to go back, it's going to trigger you to go back again and to use the media. And I see it in different times in my clinic with adult ADHD specifically. People come in the university, in the clinic asking, do I have ADHD? I saw this TikTok. And when you open TikTok and you watch a video, then other videos are going to come, and other videos are going to come. And this will confirm to you that you have the things that you're looking for. Hashtags is the same thing. When you start opening certain hashtags, now X will, certain tweets are going to pop up about the same things that you're looking for, and then you're going to be like, maybe I do have this, or maybe I should believe in this. Peer influence in this stage of development it's huge. It's one of the major influences. So take it to the virtual reality, it's the same. It affects self-esteem and self-concepts. It could increase involvement in risky behaviors, and it could affect mental health in a positive or a negative way. So the challenge here is that the peers are present even when you are alone, because you're alone with your phone. Looking in their blogs, in their Facebook, tweets, whatever. So social media permits the adolescent to be observed also by their peers. So you're observing others and they are observing you, and then you're going to be influenced by them. And interestingly, substance use is more with adolescents who observe other adolescents that are using. They take the message as positive, that this is something cool to do. And in one study, they found that viewing friends' substance use posts increased their likelihood of using alcohol the year after. So are we connected when we use social media or isolated? So in different studies, I found that if you spend lots of time on social media, this will decrease the perceived peer support, increase the loneliness, the sense of loneliness, and also you will feel envy and jealous of people. Popularity, of course, the fashionistas and the others, people could be popular in a positive side, and we saw some people who got famous or popular in positive regards. However, there are people who got famous for aggressive behaviors and other pranks or other behaviors. So, going back to social media use and adolescents' mental health, social media and depression. So there are many studies about that. However, most of them are cross-sectional and correlational. So just keep that in mind. Adolescents, in one study, they found that adolescents with depression were more likely to use social media. So depressed adolescents go to social media more than adolescents without depression. Heavy use, which is in that study defined as more than 4 hours a day, predicted depressive symptom a year later. So the risk factors is that to develop depression for adolescents who are using social media, who are using it passively, just to look on other people's posts. Okay, I'm going to go to Facebook to see, or Instagram to see where this person traveled, what are they doing. So passive use, rumination, if the adolescent already have rumination, a long duration of use, being a female, and actually this one, being a female, is just increase the risk of depression in general. If the adolescent already have low self-esteem, and the age. The younger the adolescent, the more likely for them to develop depression. Now for self-harm behaviors and suicide, again, exposure to self-harm content and social media will increase the risk. Having negative reinforcement or normalization. Some people go to sites where they normalize self-harm. It's normal to cut, it's normal to do this and that. Cyberbullying increases the risk, and heavy social media use increases the risk of self-harm. The problematic use or internet addiction, one of the main factors is the fear of missing out, that we're missing out things and they were going to go again and again to check what others are doing. Being a female, having insomnia, not sleeping at night, will increase your use, and increasing the use will cause insomnia. Passive use again. Cyberbullying and cyber victimization. One study found that after they followed them in a year, that people who are being bullied online are more likely to develop depression. Those who have depression are more likely to get bullied also. So having a mental illness, you're going to be more likely to be a victim. So those who are victims of cyberbullying are twice likely to have self-harm behavior and suicidal attempts. And if you are a bully and a victim, both, you have double the risk. So the adolescent who bullies others and get bullied will have double the risk to self-harm or to try to commit suicide. I think Dr. Amel spoke about sleep, and it's the same thing with adolescents. So in terms of multitasking and attention, potential effect of using media or social media on attention is that there is a habituation to high arousal level. So they get bored. Whenever the phone is not there, we're bored. And we hear it with kids in different age groups. Becoming sensitive to irrelevant information. When there is a huge information, you cannot focus. You're overwhelmed. And the last one is attentional control is something we train ourselves to do, to pay attention to certain things. So if we're using the media a lot, we are not training ourselves to do that. So we're more likely to get distracted. Now, the chicken or the egg, which came first? People who have inattention, they are more likely to use the media. And if you use the media, you're going to get poor attention skills. So kind of both are affecting each other. But again, it doesn't cause ADHD. It's going to make it worse if it's there. And it's going to make generally the attention worse if we are multitasking. So for female, does it increase the risk? In different studies, although I mention it as a risk factor, but it's a risk factor for depression in general, they found that being a female will predict social media use. It will be more rather than the opposite. Teenagers, adolescents who have existing mental health vulnerabilities are more likely to get bullied, as we said before. They tend to have low status offline. These are more at risk to have depression or more mental health issues in the future, and heightened sensitivity to social evaluation. So basically the same risk factors for the real life risk factors for adolescents goes with social media. So are there good sides for social media? Yes, because many adolescents look for information and try to find support through social media. So they tend to try to find support groups when they are in a struggle. And in different studies, I found that. So the peer support is one of them. Social media can facilitate private interaction for people who are using it for private peer groups, and they could have support and social connections. Just to keep in mind that there are lots of methodological challenges in the studies about social media and teenagers. As I said, the last one, as you see here, it's correlation. So correlation doesn't mean causation. So most of the time they're asking the adolescent, how much time do you spend on social media? And again, there is a bias here. There is a recall bias. There are different biases here in these studies. There is lack of control or comparison groups in many studies. The rapid development of the social media platforms, this is another challenge. So we're measuring it before with TV or whatever. Now there are many social media platforms that are developed. And we cannot generalize what's happening in one media to another media. There are some medias are more like picture-prone medias like Instagram. There are others where you can type and chat with others like Reddit, etc. So they have different aspects in them. The last thing I'm going to say is that there is a review in 2020 trying to see the link between adolescent digital technology use and well-being. And in that review, they found that most of the studies were inconsistent, and those who had effect, it was a small effect. Thank you.
Thank you, Dr. Ali. Really appreciate it. Was really wonderful presentation. Now we can have a discussion. If you can, Dr. Amal, please join us over there. Have a seat, please. We're ready to take any questions. Yes, please.
Good morning. I want to ask the psychiatrist some questions about social media addictions. There is any specific tools to diagnose or measure, and any comprehensive intervention team working in Saudi Arabia to control this social media addiction or internet addiction? Is there any programs, or is it to plan for that in that regard?
Sorry, so there are two questions, right?
Yeah.
Can you repeat them just one by one?
First one, any specific tools to measure or diagnose the social media addiction or internet addiction in Saudi Arabia?
In Saudi Arabia?
Yeah.
I think there is a tool, but in general it's used in research, not in diagnosis. In generally talking, all tools are used to screen, not to diagnose. But yeah, there is a tool, but not in Saudi Arabia. It's in general, and it's mainly used in research, not in the clinic, really.
But I am an occupational therapist. I know some of the tools is there, internet addiction test and some of the social media addiction test may implement in future to do some research also.
Yes.
Yes, and also any comprehensive medical care or rehab care to control this social media addiction? Is it working in Saudi Arabia for any hospital based or any places?
I think this will go with psychological addictions, and generally people who are specialized in addictions could treat that, but there is nothing specific for this as a sub-specialty, let's say.
Okay. As a psychiatrist, I request you to create some of the awareness in future to work with psychiatrists and clinical psychologists, social worker and psychiatric occupational therapists to control over to better in the kingdom and the country for this. Thank you, sir.
Thank you.
Good morning. Thank you for all for this interested and informative lectures. I have a question for Dr. Amal regarding the application. There is any organizations or association that might recommend or give the approval of the SAM application for children, just in the same way like the medication approved by the FDA? Is there any organization or association that can give the approval for some of educational applications in the mobile or in the social media for children?
I'm not sure if I understand all your question, but are you you're saying that if there is an application to control the social media for children, or what?
I mean, there is an organization that give the approval or any associations that give the approval of some of the applications.
You mean like
mobile.
categorization of the application, if it fits the children or not?
Yes.
I'm not aware there is a local one, but there is obviously an international code for all the programs and the movies and the applications that is, they say 3+, 5+, 13+. But as Dr. Ali mentioned, nobody really reads, and most of the kids, they may even fake their birth here just to be able to apply to these. So they could bypass it easily. But I am not aware of any local ones. If anybody has a better answer, they could chime in.
Okay.
We have a question to Dr. Amal.
You?
Yeah.
Okay, go ahead.
You show us the guidelines for screen time for the normal children. Is there any relation between the screen timing? We know that with the epileptic patient, we know that the flash of light and sleep deprivation all can provoke seizure in epileptic patients.
Yes.
So is there a guideline for an epileptic patient for the screen time? Is there a relation? Is there any study showing?
This is a very specific question, but a beautiful one, honestly. I need to look into it. There could be some in the epilepsy associations I am not aware of, but it is a beautiful point that I may add to my next lecture about the effect of screen and seizures, because we know that it can provoke epileptical attacks, really, but I'm not aware if there is a specific guidelines for these children. But overall, especially we see that in Ramadan, the people are sleep deprived, they are on the screen all the time playing, and they have seizures early in the morning. So I'll look into it. Thank you. Yeah.
Okay. Dr. Baligh maybe has comment.
Thank you so much. Actually, I was going to ask a question, but then I can comment on that one. For the patients who have photosensitive epilepsy, one of the tests that we do during EEG is the photic stimulation. So that helps us segregate these patients who are at higher risk of developing these seizures. It doesn't matter if he uses the mobile too close to his eyes, he would have a seizure despite whatever time you give him. The other element that you've mentioned is the fatigue or sleep deprivation, or this also adds to the issue of increasing the risk of seizures. But I think it's a very good question that I myself will also look into it. My question is, can we give children melatonin, whether my children or recommend it to our patients, so that they can get, quote unquote, a healthy sleep?
Actually, there is a good study actually about the children with developmental disorders that they may lack the right secretion of melatonin. So whenever we take a full good history or detailed, and specifically if they have initiation problem with the sleep, the recommendation we start melatonin. Maybe it's not becoming part of the obvious recommendations, but I think it's coming soon. So can we give melatonin? Definitely we could give melatonin. Now, is there any precaution? There is no known precautions. The side effect minimal, maybe headache in some of the children. But, and for how long? We don't know for how long we could use melatonin. That's another question. But definitely, yes, we could give them melatonin, but look for what is the reason for them not sleeping well. And I have full lecture about sleep hygiene, because we need to do so many things before we go into giving melatonin, or we give clonidine to kids with ADHD also to help them sleep. So sleep hygiene first, and yes, you could give melatonin. Mother Dr. Ali, if you have...
I agree. I mean, we're not solving a problem by a pill. If they are not sleeping because they are using screen, then we're not going to give them melatonin to sleep. We have to do the sleep hygiene first, and as you said, like 1 hour before bedtime there is no screen use, and that maybe the phone or whatever should be outside the room so that they don't sneak and use it.
Dr. Ali, Pediatric intensivist. Thanks for the speaker. My question for Dr. Amal. Really thank you for this interesting lecture, which I think should be, broadcasting for all the publics. It's a pandemic problem. This screen and what's called staying long time on the screen. But my question now, we are coming what's called education, electronic education, or distance education. So it need also to stay long time on the screen. How will we try to just solve this problem that most our children now from the maybe even the preschool, they are using this what's called electronic education.
Yeah, thank you so much. If you notice that with the American Academy recommendation, that they left more than 6 years open, so there is no limited hours because of that issue. They started very early now, exposing these children to longer hours, searching for their project or answering a question and bringing an answer from the net. So that's not really considered as an overuse of screen. We're talking about these kids who are, okay, searching for the dinosaur era, and then they're playing on the side on their other games. That's the problem here. So that's why it is better, and by the way, maybe I did not mention that, but children who are younger than 12, I rather that they use the computer in the living area where you could see what they are doing and how they're doing it, and they're not going to other sites that you don't approve. Because if they're saying, oh, Mom, I am on the screen because I have a project, and they're playing Roblox, you don't know. So it's better for you to put them in where you could see their screen, and without really coming on their back, but they're there, you could see what they're doing. So yes, digital teaching or digital era of learning is here, and it's gonna last, even for us as adults. And we need to train ourselves not to be very distracted and going on another device. Because what happens, and that's another study, that people are now, the generation, the alpha generation in particular, they could be on 2 to 3 screens at the same time. So their iPad is there, their mobile and their phone, and their TV maybe is open on this. So they are on more than one device. See, the attention part is a disaster. So they have no attention attention to any of the multitasking. They're not doing well at any of them. So thank you for the question.
Assalamu alaikum, Khalid Akhlawi. Thank you for your time and lecture, very informative. And I think this question applies to all age groups. One of the issues of social media use is they are designed to self-propel and self-fulfill what you're searching for, hashtag and such. All of that so that they can use the app more, to be more addictive. They are designed this way, we all know that. And I wonder, since on your review, did you come across any practical ways for adults or children to limit that tendency so that we can have more of an expanded worldview? Because if you go and search for the same thing and look at the same thing and you're self-fed the same thing, you're going to have a very limited worldview. What can we do so that we can expand it? Can I imagine maybe an AI assistant that is going to look at my social media and see that my behavior, maybe recommend that maybe you're looking too much into soccer, let's look at something else. Are there any practical applications of this?
I think that's a challenge. I remember a case that I saw a child who was scared. He saw something violent in TikTok, and then things keep popping up in that way. And he didn't know that there is a dislike button in TikTok, that you could go and say, I don't like this video, and then you're less likely to get these videos. However, without doing anything passively, as you said, like the platform is made in a way that when you see something in a certain time, or when you see it in many times, that many videos from the same thing are going to come up. This is passive, but you have to actively say, I don't like this video. And this is a challenge, I think. Again, one of the things is the age. If we consider that, okay, this is maybe not appropriate for this age, who are 8, 6, or 7, or whatever, but unfortunately now most of kids have most of social media, and they are okay to use it by the parents, with most of them with no supervision. And even if there is some supervision, you cannot be there like all the time to look at what they are, who are they chatting with or whatever, and what are they watching. So maybe in some, and again, I'm saying in some of them, maybe there are some criteria where you could choose initially that I don't want to see this, I don't want to see that. But how many of us go on, even as adults, who go and look on the preferences and see, can I remove this, can I add this? Most of us, we don't. We just download the app and start using it. Same thing is with kids.
Can I add to this? First of all, for any problem, you have to be conscious about it. So consciously, cognitively, you know it's a problem. One, إرادة, well-being, مش well-being, willpower. You need the willpower. Says, okay, I want to change my way of doing things. Third, the screen can help you. It has a screen exposure, صح? You turn it on, you check every day, what did you get exposed to? How many hours did you spend on social media, or did you spend it really searching Google or YouTube? So that will give you an idea what you're doing and where you're spending most of your time. And you'll be surprised, trust me, that you think, oh, I spend only 1 hour. It turned out to be 3-4 hours on that certain things. And for children, we need to be نموذج. We need to be نموذج إلى أطفالنا. We need to be the ideal for them. If they see us on the table watching something or answering something, they will do the same. صح? So we need to be their model for them, and use other. There is some apps, by the way, they don't come to my mind now. App that control really what you see and how much you see. And you need to say, you know what? I'm going to turn off my phone. I am not on call. I don't need to hear anything for at least these 2 hours that I'm spending with my family. So it needs a willpower. Without a willpower and intention to make a change, I don't think anything will change.
Thank you, Dr. Amal and Dr. Ali. I think we should conclude now because it's time for a break before we start.
We'll Thank you, our speakers. We really appreciate the very wonderful presentations. We're honored to have you here. We're happy to present you with this graduation. Thank you very much. Thank you, Dr. Amal. Thank you, Dr. Amal. Thank you. Dr. Kamal, thank you very much. Thank you.
And lastly, the winner for who answered the quiz the fastest, Dr. Dua Zaki. Yesterday, Dr. Ahmed won, and today, Dr. Dua. Thank you very much. We'll have very short break, 5 minutes, then we'll come back for the second session. Thank you very much.
We'll resume our session. Assalamu alaikum. AlHasa, Pediatric Consultant, King Faisal General Hospital. First of all, I would like to thank the organizing committee for inviting me and welcome all to the second session of this wonderful conference. So the first speaker, it will be Dr. Tamara Sambal. She's gonna talk about the impending equality and patient safety through the digital channels. Dr. Tamara, she joined Saudi Aramco Medical Organization and held various leadership positions. She started to work with Medical Informatics Service as the physician representative of various IT projects and enhancement. Then she obtained professional certification in healthcare information and healthcare management, completed the Harvard DTH Chan School of Public Health Leadership Strategies for Information Technology and Healthcare program. Dr. Tamara currently serves on the IT stream and also the chair of Data and Documentation Governance Committee. Welcome, Dr. Tamara.
Good morning, everybody. Just a quick disclaimer, nothing to disclose, and we're going to be talking about all these, so we don't need to go through them. So, anybody recognize this painting here in the audience? Okay. Well, believe it or not, this painting was not painted by a person, but it's generated through generative AI art. This painting actually won the first prize in the Colorado Art Contest. And it was drawn by generative AI. So nowadays, AI is doing a lot of things. By a show of hands, how many of you know of ChatGPT? Great. Please keep your hand up. If your hand's up, keep it up. If you're using ChatGPT. Great. So you can see what's coming in the future and how it's going to be transformed. Let's talk a little bit about ChatGPT. 90% in the bar exam. Would anybody dream of that? 88% in LSATs. ChatGPT 4 beats 90% of humans in the world's toughest exams. The purple bar you see up here is ChatGPT 3.5. The green bar is ChatGPT 4. And this is all within a few months. So imagine, just with those few months of learning, how fast it's become. I was just recently in our EMR EPIC conference, and now they're talking about generative AI responding to patients' questions. So instead of the patient asking the physician the question, the patient's asking generative AI the question and responding back. And guess what? The response from ChatGPT is more empathetic than the response from the humans. And they thought that actually it's the human that's responding, not ChatGPT. Because why? It's more empathetic. It was searching the chart, saying that this patient had a grandchild, so he was asking about the grandchild. Of course, when us doctors reply, normal result, ma'a salama, that's it, you know? So it's generative AI is coming to many things. So, To Err is Human is published by Institute of Medicine, and it's saying that 44,000 to 98,000 patients die from medical errors every single year. The Journal of Patient Safety came to tell us also that around 440,000 patients each year die from preventative harm that could have been avoided. Now, this is just the tip of the iceberg. This is the people who die. We don't know about the people who don't die. I'm going to go through a few of his exams. So meet Sebastian. Sebastian is a 3-year-old, and what he did suffer from was short stature. So his parents brought him to the hospital to see why this is causing. So they said, let's do a growth test for him. So instead of giving him the amino acid arginine, they give him 60 grams, which is 10 times the dose he should get because of just the bottle got labeled wrong. The boy developed cerebral edema and went on to brain death. Pat, Sheridan and Anne, these were wrong twice. First, their child, Cal. Cal had neonatal hyperbilirubinemia, and he went home undetected. Nobody detected it. He went home, developed cerebral palsy afterwards. His poor father, Pat, died at the age of 45 because he had a tumor that was diagnosed as benign on the radiologic when it was actually misdiagnosed. And this little girl, Josie King, well, what happened to Josie? She was taking a bath, she got into hot water, and she had some burns. They took her to the hospital. It should have been a routine 2-week stay. But what happened? She developed 2 days before she was discharged an undetected central line infection, and she passed away. So why digital channels? Why are we talking about digital channels? So I don't know if you guys remember Captain Sully, the one who landed the plane in the Hudson River. Well, he was comparing this. If I told you, we talked about it at the beginning, the 220,000 Americans that die, just American, US, every year from preventable harm, okay? If I told you now that that equals 2 airplanes, big commercial jets crashing every day, would you guys get into an airplane? How would we feel about getting in an airplane if I knew that every day 2 planes are crashing? Imagine, that's how much those 220,000 are. So Captain Sully has become an advocate for patient safety, and he was comparing those planes that are falling with patient safety, with what we do in hospitals. And because when when a big jetliner crashes, many people die at a time. But with healthcare, it's 1 patient at a time, 1 family at a time. So it goes under the radar, it goes undetected. To Err is Human also compares that, compares what's happening, and says aviation safety accepts nothing except 100%, So what happens if a plane crashes? There's big investigation, they go out, they get the black box, they investigate, they train, they re-emphasize. What do we do in healthcare? Do we go through that? Because in aviation, nobody will take except 100% as the normal. So we talk about embedding digital health quality and patient safety in digital channels. Why? Because of 3 things. It's the influence of the people, the organization structure, and the policies, and technology. So all 3, people, process, technologies, all 3 that need to be aligned to influence behavior basically at the sharp edge. It's only through pooling and aligning all these 3 that we'll get to quality and patient safety. Now, along came the promise and said, digital technology can do this. It can improve patient safety, but there's always 2 things that we have to think about. We have to think about the extrinsic ability of these technologies to drive patient safety. At the same time, we have to think about the intrinsic safety of these technologies. So we have to balance the 2, because not every technology that's out there is also safe. So patient safety has been on the agenda, and it's been gaining a lot of momentum in the past 10 years. And because of the promise of how it's going to improve outcomes, improve access to care, and reduce cost. And now, digital transformation is intrinsically related to safety, because it's digital transformation and digital technologies that we can actually automate and make this better. So I'm going to go through some of these technologies under different themes and show you how we can utilize those to improve patient safety. So first of all, talking about empowering patients as partners in care, because we don't do care to patients, we do care with patients. So starting with patient portals and bedside, because patient needs to know where their case, and they need to know what's happening to them, and need to be a partner in the decisions that are being made. We talk about self-triage, symptom checker, because we don't need for things to escalate at home when you kind of can get, because you also don't want more care is not better care, and you don't want less care. You have patient questionnaires, because we don't need to wait for the patient to come to the hospital. We can outreach to them. Because guess what? Where does the care happen? It doesn't happen in hospitals. It doesn't happen in clinics. Most of the care happens in patients' homes and their work. And that's where we need to make sure we send the care to. And wearable and remote monitoring, because I guess where is all that work happening? Is it coming only when we're checking his blood pressure in the hospital, or is it happening when they're in their homes? We talk about prevention and before intervention and what the technologies that empower that, including risk stratification. So we're able, because we can't take care of everybody all at once, we need to know who are the patients that need the care the most and be able to outreach to them. We talk about care scoring, risk scoring, so we can determine the at-risk patients. And that can include through importing their data from their wearables and the questionnaires. And we talk about actionable care gaps, because we know clinicians like me are really, really busy. So we want to really make it very easy. Child needs a screening, one-touch order. You don't have to put in eye screen, hearing screening, because if you make it that hard, they won't. It's not going to happen. Clinical decision support with pathways, caregiver and patients, and evidence-based order sets. Because pathways are not just for clinicians, they're also for the patients, because the patient needs to know what he should be doing, because he's in charge of most of his care, it's not us. AI and cognitive computing models that tell us, like the few cases I talked about before, who's at risk for sepsis, who is at risk for deterioration, so we're able to pick that. And those are also on the outpatient and on the inpatient side. Closed loop medication, specimen extraction, milk and blood administration, because we can just scan to make sure we get the right dose, right patient. And then technologies empowering safer care, health information exchange, because we all know patients are getting care in different places, so we need to be able to exchange and get the information of what happened in the other hospitals. Self-service reporting for data-driven decisions, because we shouldn't wait for a report to be sent by somebody. The clinician should have what information he needs at the time of making that decision. Again, actionable data at point of care. Not only do we give him the data, but we give him the click button to action that data. And then, let me ask you, how many here share their clinical note with their patient? Let's have a show of hands. Great, I'm glad we're starting that. So, open notes. Why are we afraid to share our notes with our patients? This is their note. Why do we always say, no, this is only for the doctor? Oh no, the patient might misunderstand. We share the notes. Let them know what's going on. Let them be a partner in care. They're more educated than us. Forget about Dr. Google. You have now Dr. ChatGPT, mashallah, ahsan min Dr. Google 100 times. And then you want some registry measurements and benchmarking, because we also, again, more care is not better care, so we want to make sure we're providing the appropriate care and benchmarking it through registries like STS, NISQIP, NDNQI, DATIX, NCDR, and Press-Ganey, also to check about satisfaction. Technologies empowering safer care include improving access through telehealth, so synchronous, asynchronous visits, because synchronous is when they're happening with the doctor and the patient at the same time. Asynchronous is when the patient sends a doctor message, he processes it, he sends it back. So those are asynchronous e-visits. Telehealth, B2C, which is business for us with patients, but now even in Saudi Arabia, we have the largest virtual hospital in the world that's doing telehealth B2B. So you don't, in some areas where they're remote, there's not enough specialists, we can utilize this kind of technologies. And then we want automation, allowing staff and caregivers to practice at the top of their license. So pharmacy robotic automation, yesterday, mashallah, we saw it in Musa Hospital, beautiful box dispenser, the robots. Imagine how safe that is. Not a pharmacist putting the tablets, putting the wrong label on, the medication coming through, so decreasing a lot of those errors. Chatbots that are going to be automating a lot of the work and those repetitive tasks that don't need us to do. And then natural language processing ambient, in which actually the system is, imagine the clinician is sitting there talking to the patient. Everything's hands-on with the patient. He goes to his workstation, note is already conducted, because in the background, ambient is listening, and it's recorded the whole conversation. It's actually even coded the chart for him, suggested the order sets, and actually alerts him to say, hey, you told the patient that you were going to give him this medication, but actually we tried that. I've checked the chart. 3 years ago we tried it, it didn't work. So imagine that technology. And then prevention before intervention with early detection of disease. We saw Dr. Selwa's wonderful AI-assisted retinopathy, which we're actually piloting in our hospital. Also for patients with diabetic foot, you can also do peripheral vascular screening instead of with the pins and the needles at 20 tests. You can do thermal scanning and AI to tell who's prone for a diabetic ulcer or diabetic foot. And then wearable sensors that you can put on patients, Right now they're in the rings or in the watches, but in the future, I think somebody presented yesterday about the pulse variability. I wear my ring all the time and I can tell my readiness score every day and I know how I'm stressed or not from my pulse variability. Moving into the future, precision medicine and gene editing. Dr. Mariam spoke a lot about it yesterday. So in the future, we're not going to be doing medicine like we're doing right now. We're going to have precision medicine. And we're going to be talking about things like CRISPR, gene editing, because in the future, we should be able to switch out the genes. Just recently, for sickle cell disease, thalassemia, and now it's curable. Why do we need to give patients blood transfusions, have them come back and forth, when we can actually switch out the genes through CRISPR and use gene therapy? Digital twins, in which we do a copy of the person in technology and then actually start to ask the algorithm, because we try it. And by the way, in factories, this is the normal, but in humans, it's not the normal yet. And of course, digital diagnostics and therapeutics. Now, it's very important, again, to balance these technologies. And I mean, you heard about all these great ones, but in the end, we should do no harm. So how do we ensure that these technologies are safe? Well, first of all, it's very important to do market analysis and literature review. Definitely has to be Saudi FDA registered, has to be and gone through clinical trials, so make sure you look at that data. Conducting risk assessments. Prioritizing, even when we come to implement these great ones, we have to make sure that we have a user-centered design, because again, the best technology, if not implemented right, disastrous. Doing a proof of concept, like you see with a lot of our technology, we do a POC, we check the sensitivity, specificity, making sure it's safe, and do our own internal clinical trial, in spite that it's done already. And then usability testing to make sure that it's actually usable the correct way. I had a very nice video, which I don't think I have time to show, but really nice of how the wrong thing can be used in the right thing can be used in the wrong way. Training and education, that's the crux, because you have to show people how to use that technology and how to even question it. Nowadays with the algorithms, you have to be able to question them. And then continuously monitoring technologies. So in the end, I'll close by coming together is a beginning, staying together is progress, and working together is success. It's only by coming together and collaboration and working together with a shared commitment of embedding patient safety in all digital channels that we can make it to happen. Using digital transformation as an enabler to improving quality and patient safety is where we're headed for the future, for a more safer future for all our patients. I will say, by coming together, one hand can't clap, two hands can clap, but many hands can clap very loudly together. Thank you very much.
Thank you, Dr. Tamara, for that wonderful talk, and we are happy for this. Listening this, some technologies we needed also in our department, in the emergency department also. Let me introduce the second speaker, Dr. Umar Al-Khatib. Dr. Umar, he is working in the King Fahd Medical Cities as the chairman of the neonatology and the chairman of the neonatal accreditation compliance and policy procedure committee chairman, and also editor of evidence-based neonatology social media team. Dr. Umar is a holder of a high specialty degree in the pediatrics from the University of Jordan, Jordanian and American Board of Pediatrics. Dr. Umar is a member of many national and international societies, and he is an active trainer who is involved in a lot of teaching roles. Welcome, Dr. Umar.
Thank you for the conference organizers for giving me the honor of presenting in this innovative conference. The idea is really exciting and interesting. It's the first time for me to come to Hafuf, and it's really a pleasure. The city is beautiful, the people are welcoming, and it's a great opportunity for connections. My talk today will be, inshallah, about the modern media for neonatal education as a consultant neonatologist, but it will also reflect on pediatric education, inshallah. I have no conflicts of interest to declare. This is what I will discuss today, inshallah. We will begin by reviewing the impact modern media has had on global society and in the recent decades, and then we will address the public health challenge known as the evidence-practice gap. I will then spend the majority of my presentation talking about modern media, including the social media, that will help us narrow this gap, اللي هي evidence-practice gap. To begin, what do I mean when I say modern media? By modern media, we refer to the concept that academic media scholars refer to as new media. Basically, cultural objects which use digital computer technology for distribution and exhibition, such as computer software, internet applications, mobile devices, phones, computers, and so on. This terminology has become so familiar, in fact, that it may be difficult to recall. This is still fairly new in global society. يعني بأعمار الأمم, what's happening now is really new. If you go back to the 1970s, 1980s, and 1990s, the life was completely different than what's happening now. Let's see the internet usage in 1982, for example. Almost no signal. Only experimental in Botswana and Thailand, just like experimental kind of internet. In 1995, all countries had internet, but the percentage of users were about 10%. In 2000, now the numbers have increased. 2006, more and more. And 2022, year before last year, all countries had internet. Some countries had 100% of their population using internet. So this has had an impact on global society in healthcare provision, in healthcare literature, and how to find new evidence compared to 10 or 20 years ago. Internet users have gone exponentially higher than before. Currently, more than 60% of the world's population use internet. The way we access modern media has changed. Remember those old computer, صخر مثلا, or the old IBM, when the only way we access digital media through CD أو الديسك اللي هو 3.5 إنش وال5 وربع وهذه الأشياء. Now things are completely different. Nobody even almost use CD. يعني حتى CD أصبح something of the past. Now everybody is using mobile phones. 1982, mobile phone subscriptions almost nil. Very few countries had mobile phones. Very few people had mobile phones. Compare this to 2020, to 22, 23, 24. Everybody is carrying a mobile phone. So this has become currently the standard of new media. خلاص نسينا التيفيز والراديو. أصبح the media now depends on mobile phone technology, mobile phone applications, mobile browsers, and everything is through your personal device. But this is a pediatric conference. How can we bring technology to improve the pediatric education and neonatal education? So that's what I will talk about, the evidence-practice gap. The evidence-practice gap refers to the discordance that exists at any point of time between the available evidence, اللي هو available research evidence, and between the actual care delivered to your patient. There is a gap. تمام? This gap, according to the institutes of medicine in the USA, they say there is about 17 years, 17 سنة average بين available evidence and the application of this available evidence to your patient actually. It's a huge gap. I think it's the biggest challenge currently healthcare providers and patients face. إن إحنا في عندنا أشياء proven to be good, but they take too long to be applied. إيش السبب؟ The causes include unprecedented advances in medical science technology and increasingly complex healthcare. More to know. For example, if you use the infant, premature in the PubMed search, كل سنة تقريبا currently 5,000 to 6,000 new publications involving this terminology اللي هو premature infant. 6,000 publication في السنة الواحدة. In the 1980s, there were about 1,000 publication. So the body of evidence is, know this very well. You are attending deliveries, you are providing consultations, you are doing procedures, you are covering the clinic, and so on. Everybody is busy. So how can we use the modern media to close this gap اللي هي بين research evidence وبين clinical practice? Now, there are, as everybody knows, textbooks. Fanaroff في neonatology معروف. The biggest and best textbook في neonatology is Fanaroff. في pediatrics, Nelson textbook في pediatrics. And then there are manuals like Gomeldan manual of neonatology, or Washington manual of neonatology, or Harriet Lane, or all these textbooks, alhamdulillah, are now available on mobile device. So this is one way, right? In King Fahd Medical City, mashallah, it's one of the biggest, I think it's the biggest hospital في المملكة من ناحية عدد الأسرة. There is the women's hospital, there is the children's hospital, there is the L&D, labor and delivery, and you go walking, you go moving between buildings. So we're using this time during walking and reading what's, يعني when they call you for a consultation, you open your phone, مثلا حالة hyponatremia قابلناها من أسبوعين. So I opened Fanaroff on the go to see what's the latest updates on management of neonatal hyponatremia, causes, management, complications, therapeutics, and so on. طبعا medical journals are now available on mobile applications like Brown Zine or Read by Q, XMD, and so on. Medical conferences you can attend on the go. Register on the NIC University website, and there are a lot of conferences that you can attend visually. Personalized education with search, Google Alerts, Mediu, PubMed, and so on. Like مثلا this kind of search, diuretics and infant premature, and then you tick the box here for email. Send me daily emails if there is a new article on this particular topic. It's crazy. You want a very, very specific search item that you want PubMed to email you on a daily basis or a weekly basis, giving you new literature on this particular topic. How about neonatal websites and the blogs? I think people here who are neonatologists know Michael Narvi, All Things Neonatal. Neonatal research by Keith Barrington from Montreal. Those guys have great neonatal blogs and websites. There is also 99 NICU for online discussion boards. There are neonatal applications, something like mobile app to give you what's the depth of the UVC, what's the size of the ETT, how much phototherapy does the baby need, is his bilirubin exceeding exchange level or phototherapy level, and so on. Mobile applications for this, not one or two, there are a lot of applications. Even I know a colleague here in Saudi Arabia who invented a mobile application for neonates. So it's getting crazy. Social media, Facebook, Twitter or X now, Instagram, LinkedIn, ResearchGate, Doximity, and so on. It's, again, those are the new media. Everybody is using it for more education, more literature search, and so on. So I'm going to talk now about the social media and the EBNEO, which stands for Evidence-Based Neonatology. EBNEO, it's present on Twitter, Facebook, Instagram, LinkedIn, and it helps to close the evidence gap between research and practice. Everybody knows what social media is, and I'm not going to spend a lot of time on this. The social media users are more than 4.5 billion people as of 2021. I did not find more recent number than this, but now I imagine probably 5 to 6 billion people are using social media worldwide. The evolution of daily time spent using social media, average adult and children's, more than 1/7 of your awake time, you are using social media. 1/7 of your awake time. So EBNEO, is the evidence-based neonatology, was founded in 2015 by those three guys. This is Stefan Johansson, is a Swedish doctor. This is Harish Kirpalani, the husband of Barbara Schmidt. People of neonatology must know Harish Kirpalani, one of the greatest researchers ever. And then the last one is Michael Norman. This is the mission statement of EBNEO. It's a non-profit organization that nourishes a vision that all neonatal care should be firmly built on best available evidence. The vision includes a passage from research-based knowledge to implementation in neonatal care. Basically, it helps to close the gap, research or evidence practice gap. Because of the limited time, I'm going to skip a few slides. We opened a website in 2016, and we started publishing, and then we opened, in 2018, we started our Twitter, Facebook, and Instagram accounts. Alhamdulillah, users now are close to 15,000 on Twitter, 7,000 on Facebook, and about 9,000 on Instagram. With monthly newsletter, 6,000 users are accessing our newsletter. There are a lot of Twitter or X handles that talk about neonatal science and neonatal literature. Those are the most recent or most famous journals: JAMA, Lancet, NEJM, and so on. I'm not going to talk about Twitter a lot because everybody here knows what is Twitter, hashtags, and so on. But the growth of Twitter users and social media have gone crazy over the last few years. This is the team of EBNEO. Worldwide, between Saudi Arabia, myself, USA, Japan, Australia, UK, Canada, and it's a worldwide organization. Basically, we scan on a daily basis new literature coming in neonatology. We scan the best journals. We use the impact factor to know the journal weight and the literature level. And so after we identify a paper that's worthy posting about, we summarize the paper in a format like this: first author, the journal, and then the title of the paper, and then a short summary. And we tweet and post a Facebook and Instagram post about it. We also have the email newsletter. I'm the one that's doing the email newsletter on the EBNEO. And then we help with evidence dissemination. But remember, technology is best when it brings people together. So we met in the Pediatric Academic Society's meeting in 2018. That's when we invented, or let's say coined, the term NEO-EBM. This term here, NEO-EBM. It stands for Neonatal Evidence-Based Medicine. And if you go on Twitter now and search NEO-EBM, thousands of tweets, sorry, X, not Twitter, If you search for neo-ABM, you will find thousands of tweets about the most recent evidence-based neonatal literature. The use of neo-ABM has gone up significantly, and if there is an application called Sembler. Sembler uses a hashtag and sees what are the topics that are being discussed on this specific hashtag. So on the neo-ABM hashtag, those are the topics that are being discussed here. Infants, preterm, neonatal, outcomes, published study, blah, 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 those things, okay? You can, if you have any hashtag that you want to assess, you can use Sembler. This is an example here. So a doctor called Jonathan Swanson asks on Twitter, neo-ABM community, what is the earliest you would get a cranial ultrasound on a well-appearing golden hour infant, say CPAP, low oxygen, to screen for IVH? And then answers. So if you click on this neo-ABM, you're gonna find a lot of questions, a lot of answers, and so on. So EBNEO is an international forum to communicate and support evidence-based neonatal care and neonatal caregivers with best available knowledge via evidence dissemination. It's an interactive forum for the critical evaluation of the literature. طبعا في drawbacks for using social media. It's not all goods, there are bads. زي الفيك نيوز، انتحال الحسابات، زي wasting your time on social media too much, and stress and bullying that we know that happens with social media. Our Twitter users are growing, alhamdulillah, significantly. And I'm going to show you just quickly here on what happened. Okay, on my Edge browser. This is مثلا ebneo.org page. If you open this page here, loads, and this article of the month and article of the year, voting for any neonatal provider here. Those are the best papers that come up every month in neonatology. Best ever. يعني ما في مقارنة. A lot of people are wasting their time trying to find what's the best knowledge and best evidence, best paper, and they will not reach it. But we have a group dedicated, international group dedicated to gather أحسن البيبرز and give it to you in one website اللي هو الEBNEO. تمام؟ this is a monthly vote. كل شهر we publish 2 to 3 papers and get a voting process for what's the impact article of the month, and then at the end of the year we do the impact article of the year, so that we also reward good research. This is our Twitter account here. Currently we have 14,000 followers. We started with 100 followers, like almost nothing in 2018. When you imagine you have this number of neonatal providers just to know what's the most recent and best evidence coming up, I think we have done a great job closing the gap, اللي هي evidence practice gap. And I'd like to hear any feedback from the audience. If you have ever used this website or this Twitter account to improve your neonatal knowledge. And thank you so much.
Thank you, Dr. Umar, for this interesting talk. Our next speaker will be Dr. Ahmed Al-Khalifa. He will going to talk about artificial intelligence to innovate medical research. Dr. Ahmed is a pediatric critical care consultant. Dr. Al-Khalifa, he graduated from the University of Dammam. Then he pursued his residency program in pediatric from Al-Qatif Central Hospital and pediatric critical fellow from King Fahd Medical City. Welcome, Dr. Ahmed.
idea why in the next few slides. So AI was introduced very well, I think, yesterday to everyone, so I'm going to go fast over these 2 slides. So it involves the creation of algorithms and softwares to approximate the creation of a complex analysis to everyone. There are limitless uses in healthcare. We majorly categorize them into 4. The first one is administrative, which facilitates and automates the workflow for anything that can be done in the hospital. The second thing is diagnostics and image analysis, which we call precision medicine, which actually was the basics for the talks for all the speakers since yesterday. They presented many studies are talking about precision of medicine. The third one is the role of AI in medical research, which we will talk about part of it here. And the third one is the patient care monitoring, which automates everything from patient's entrance to the hospital till discharge. And this was also explained very well yesterday. It starts from artificial intelligence, engulfing machine learning, engulfing deep learning, which is most of the applications are here nowadays, which is a subset of machine learning, and that significantly enhance and automate the training of AI model. What I want to introduce more is the generative AI, which is nowadays is the talk. When you hear about ChatGPT or Brad or Bing, all of these applications are generative AI, which is a subset of deep learning. This also was presented yesterday by Dr. Mohammed Al-Khamis. It's a very nice scheme giving you the categories of machine learning. So it can be supervised, unsupervised, reinforced. So the generative AI is under the unsupervised learning. And it includes many of the applications. So what does GBT stands for, which you hear now almost on a daily basis? So G stands for generative, which means that it generates a text or a picture for you that mimics the human, let's say, practice or the human way. Pre-trained, it's trained in a set of data. And this is the issue here, that all the AI models are trained on a set of data. So we have to think the quality of this data. Where did it come from? And this is where the hidden part is. Transformer, which transforms all these things to you as an outcome. And GPT started in 2018 and reached to GPT-4 last year, and they're talking about GPT-5. Basically, these are improvements in the way it transforms the data, the crude data that they collect to you as an end user. The way GPT works is that it takes the original input, like let's take, for example, Brad or ChatGPT. They will screen all the internet content, including the good literature, the bad literature, the articles everybody writes. They will make the words into tokens, which will segregate the words, code them, put them in a transformer. The transformer will make probabilities that each word is highly probability following the previous one. That's why they create the text for you. And it will end up with recoding it or decoding it and present it to you. So the issue here is that when you write something for any GPT model, it will take your text, it will compare it to the data that they are trained on. They will see it was probably related to something they have seen before, and they will give it to you. So it's a matter of probability. These are all companies and solutions that is used in healthcare, either front end or back end. You are free to explore them, and I will share also with you my slides in the end, so you can go back if you want. So this is our talk here today. How will it facilitate our research? How to assist the researcher? So any researcher will start any research, he will start from research question, literature review, and generating an idea. From then, he will go to methodology, data analysis, and manuscript writing. So we will do the research question and literature review first. These are the most commonly 4 platforms that you hear about nowadays. Before we go into practical, you hear about prompts, maybe from Twitter or Google or anywhere. So what does prompt mean? Prompt means that it's a text that you use as an end user. The GPT model will use this text to generate for you the rest. So the quality of your prompt and how detailed it is and how it's well presented to the machine or to the app that you are using really affect the quality of the content that you will get in the future. So on the left is Brad, on the right is ChatGPT. When you log in, you will see this interface. It will give you clues or suggestions, and you can write your prompt down here. We will take an example from an ICU, since I'm an ICU physician. So I asked him, as a senior pediatric researcher, what is the current knowledge gaps in pediatric acute respiratory distress syndrome that needs further research to explore? I'm just trying to talk to him as a colleague of mine. So chat with them as any other intensivist, let's say. So it started to give me a lot of categories, a lot of ideas that they think are parts that can be done research on. A lot of similarities between the two models, but you can see that there are differences. This one focused on genetic susceptibility and role of microbes. That one, epidemiological and patient and physician, patient and parent part in the care. So it's basically like you're chatting to two different intensivists. Everyone will give you his perspective. So I asked him another question following that one, is can you tell me more about the gaps in optimal ventilation strategies, as it was one of the categories he mentioned earlier that needs more research. He went further on. He gave me some review from the literature that this is what mentioned about the optimal ventilation. Again, some similarities, some differences. I thought that I would like to focus on individualizing ventilation settings, as he proposed it as a first one. So I followed the question. Perform an in-depth review on phenotypic-specific ventilation for ARDS patients and give me a research ideas. So he will give you some review from the literature. He will give you some gaps that he identified, and he will reform them as research ideas for you. Now, the issue here is that many issues that we will talk about actually, but the issue here is that not all of them are applicable. So consider them as an eye-opener. Consider them as a chit-chat. Consider them as brainstormer for you. So it's only a matter of brainstorming. What are the gaps that these models have? First thing is that they leak deep expertise. They are giving you like a general public. They have studied all the literature in the internet, the ICU literature and the non-ICU literature. The one came from a scientist, the one came from a journalist. So we really don't know the quality of this. And over-reliance on these existing knowledges, all of them are pre-existed knowledge fed into these machines, so they have their limitation. They're not necessarily fully updated till the recent literature. And there is some contextual misunderstanding. So as I told you before, they will separate the text. They will put the probabilities. So they are not really understanding what is the context. They're just putting words following each other because of probabilities. And no emotional intelligence, which I think is a very crucial part. Now, relying on these, which is a setback, in the future, you will lose your creativity, your critical thinking to generate ideas. They have a lot of benefits that you can have a look. So, what about literature review per se? When we say literature review, we talk about evidence base. So I asked him for the same question. So I had the idea of phenotypic specific ventilation. So I asked him, give me a literature review about standards versus phenotypic specific ventilation in ARDS patients. And he started mentioning very well written text that when you read it, you think that a great intensivist has written this. But when you ask him about, okay, that's great, give me references. I'm doing literature review. He gave me 4 or 5. When you go deeper, you will see maybe 4 of them that does not exist. So he's just hallucinating for your references. So this is a big issue. And this is a big gap. So are you going to use it? Maybe no. So AI for hypothesis creation. So Derek Louis, he's a PhD in organic chemistry. He's doing a lot of research. He wrote an article. He concluded that AI is still under development and its potential for scientific discovery is very unclear. Now, another article was also published in 2030 by Dr. Mitchell Riveridge and about use of AI in medical publishing and idea generation. He also mentioned the same thing. AI and language learning models can help medical researchers find new ideas and analyze data and identify patterns. But this can save researchers time and resources and helpful to focus on publishing research. But again, the issue is credibility of these GPT machines. This is an article published And again, most of the articles that I will talk about today is 2030, so I don't have to repeat that. It's a new thing, so everybody is just publishing about it. So they tried to make a full article using a GPT model from nothing. They ended up creating an article of 1,990 something words that is fully scientifically sound, but fraud. Not really based on actual data or data from hospitals. So it's a very dangerous business. So use it with responsibility, let's say. So is AI ready? I don't think so. So this is my opinion. You have to be responsible when using them. They are good as an eye openers. So what about, we mentioned that most of the references he mentioned is like hallucinations. So what can I do as a researcher? What tools can help me? So there are other specified tools specialized in AI literature, AI helping you in literature review. One of them is this. You can write whatever you want in their search engine, and you ask for an assistant help. So I wrote for him the same question that I wrote before. It gave me this. This is the question I wrote in the top. So it gave me a quite short paragraph from the literature with each sentence is followed by a reference. And the reference is already mentioned there. You can click on it. It will open the official website like PubMed or Scope or the journal itself. And it gives you a lot of details, like how many times it was referenced, how many times it was cited, and how many articles are going with the same idea, and how many articles going against the same idea that was mentioned in the same article. You can also change the settings, like you choose the publishers or how many words or what's the length that you want, abstract only or full text. When you click on it, it will give you more details. You can filter it like PubMed. Just an AI-assisted search engine. And this is the beauty of it. So in the middle, this is the article I have chosen. The articles that are connected with a green line are the articles that are supporting the same article I have chosen. The one with the blue line are contradicting the same article. So it helped me in like categorizing the articles. These are supporting, these are contradicting. Now I can go and view more. And the size of the circle is the size of how many times, representing how many times this article was cited by other researchers. So it's a very useful tool to have a quick glimpse on articles. The other one is Elicit, which is a very similar short paragraph references. Now the beauty of this tool is that it lists for you the articles that it's got. It summarizes them for you from abstract, intervention, main finding, and also you can add more columns like results, limitation. It will make them for you in a table, and instead of you reading all the articles and summarizing them yourself. So it's a very useful tool to save time. Another thing is interact with the PDF. Let's assume that you have a very long PDF, like 20 pages, 15 pages. There are some softwares that can help you review them. One of the nice softwares are this one. You can upload your PDF, it will show it to you. You can ask questions regarding that PDF. It will answer you from the PDF itself, not from anywhere else. So you're sure that your data came from the same file that you have uploaded. And the beauty of it is that it has a tool, the one with the arrow. You can click on it, select a graph that is mentioned in the article. It will explain the graph for you in details. It will give you what the graph represents, what does it mean, what's the results, and how can you interpret any other paragraph similar to this one, which is a very ideal for those who, let's say, not expert in reading paragraphs or new for research. Now, the set gap of the previous tool is that you have to do it one article by one. So let's assume that I have 10 articles. You can use ChatGPT, but actually this is, I think, a premium tool. ChatGPT nowadays is not only ChatGPT. Every developer will make his own model, and he will publish it through ChatGPT. So one of them is ask your PDF research assistant. I tried this once. You can upload up to 10 PDF files. You can ask questions about them. These PDF files about transcutaneous hemoglobin monitoring in PIC, in general, let's say. So I uploaded the files. I asked him to summarize them for me. So he started by article 1 to article 3. Okay, fine. So I have a question now. Give me the key points of each research. He gave me like 5 or 10 points for each article. Fine, so which studies are done on infants? He started to screen all through them. He found one of them from 2 months to 17 years. He said that it is not specifically for infants, but infants were included in that sample size, while the rest of studies did not include infants even. So he really understood what I gave him from PDF files, and he looked into them, and he gave me a feedback from my questions. So it saves time. And the good thing about these last two tools, they will not look into text outside the PDF files that you gave. So you're sure that the information they give you are from a credible research that they have loaded into them. Methodology, next one. This is one of the nice websites. Most of them, if you noticed, are like search engines. You put your text, your prompt, let's say, they will analyze it, they will give you a feedback. So I added the same question. He gave me a literature review. Now, he will give you few options. Do you want me to create hypothesis? Do you want me to chat with the result that I found for you? Or you want to explore my paper? So let's say create hypothesis. He gave me, I think, around 9. So these are 6 of them. When you read them, there are very nice, genuine hypothesis idea. But most of them are like clinical trials, very difficult to be done. It needs a very well-established research center. Let's assume that you are in one of them. When you click in this icon, it will start giving you more details. So experiment number 1, from who, what, till how much it will cost. It will give you a lot of details, but very short details. So it's like an outline for what you are going to do. You have to go into depth and formulate it. But it helps those who are new to know what they should do. So experiment 1, 2, take you through all the steps. What if am I new and I want to do a hypothesis? Should I choose ChatGPT or BRAD or other GPT models that are not specialized in this area? I asked the same question for ChatGPT. It started from study design, participants, randomization, blinding. It gave specific details, age, even sample size. And it went through intervention and phenotypic specification. He started to specify them for me. He gave me a way to do data collection and even how should I do the data analysis. So it's basically like a methodology you write for any research. But when you go into details, into these lines, you find them that they are primitive. They're not like a researcher who wrote them. He can go through with a proposal with this. But if you went with the same thing that he mentioned, you will end up at one point in your research, you're lacking either few important variables or co-variables you did not include because you depended solely on this one, or you will end up with a data that it's not sound that you can do statistical analysis on. So they might help, but really need a scientific eye to look at it before they go. This is another example from BARD. I will not take time. One of the most difficult questions somebody might face as a researcher, how much is the sample size I should do for my study? And this is where usually even a good researcher go to a biostatistician to help him with, because the power of the study really depends on the sample size. So are they good in doing sample size calculation? This is an example. When I put for him a short introduction about what I'm planning to do, he told me, okay, to calculate the sample size, I need these variables. He asked about the primary outcome, the expected effect size, the confidence interval, and the margin error, which you find in most of the equations for calculating the sample size.
2 minutes, please.
Thank you. So this one, he said, it's unclear, I cannot do it. Another GPT model, actually, he gave the equation, he gave the definition for each part, and he started to calculate and gave me the end results. Sorry. So now the issue with that one is you really have to go through the equation yourself. Sometimes they give you the equation, they are doing the calculation, and you find some miscalculation there because they are treating it as a text, not only as a number. So we have to recalculate with them. So data analysis, a quick review. So there is a good platform for exploratory data analysis. You upload your CSV file. It will generate it will give you a few suggestions that you can do. It will generate the graphs for you, which is very easy, clicks. You don't have to do it like an Excel. And it will also give you suggestions on what to do. It can show you your data, and you can modify on it. And it's a free tool, by the way. This is another one. It's like a ChatGPT, but it's specialized on data analysis. So, and it's more specifically in differential data analysis, which is the most difficult part in data analysis. You want to calculate a p-value or do a regression analysis. So you upload your data. You can ask it to give you a glimpse of how it looks. It generates charts for you. Just type whatever you want. It will try to do it for you. But you have to make sure that it was done right. So the most difficult thing in these tools that they depend on either Python or R, which is a programming language, to do the statistical analysis, not the usual SPSS that we do. So it's a good idea that you have an idea what's going on. So it will show you this code whenever it do any example. So because one of the most important things, like in this study, it calculated the p-value using the Mann-Whitney U test. So why did it choose that? Is it the appropriate test? Why not T-tail test? So this is a very statistical pure matter. So when you do it, review to the statistician, unless you really know what you're doing and you know why this test was chosen. This another study was done, again in 2023. They mentioned that it has the capability to simplify complex data sets and readable summaries. But the issue here is that it's not a statistician. So it's really becoming an essential cooperative AI tool, but you have to review to the statistician to make sure that the test was chosen is right and the variable was chosen is right, the data is cleaned, you don't have outliers, you don't have missing data. You have to go through all these steps. So the last part is manuscript writing. Assume that you have a results, a table. You just copy paste it and put it in one of the GPT models. You tell them, summarize them in a paragraph for me. They will give you a paragraph, lengthy one, written, summarizing the percentages, the mean, the median, whatever. You can make it shorter by just typing to it. So it helps in reframing, let's say, the paragraphs. But again, it might sound really AI. It may not sound human. It will do it without thinking about which is important to say, which is not important to say. So you have to guide them all through. As a co-writers, there are a lot of AI tools. One of them is this one. It will give you the outline that you can bench start your typing with. Wherever you type, it will start to try to complete the sentence. But it might ask you for a few references to upload to them before you try writing, because it will try to imitate what you're writing from the references that you have uploaded. And it can give you the ability to cite from the references that you have uploaded, so it will save time to you not to go to the Word and cite there. And it will give you an AI command. You can select your paragraph, you can ask them to do whatever you want. Make it shorter, rephrase it, make it longer. It will help you rephrase and rewrite. Grammarly now, this is well known, I think, to most of you. It was used and known only for grammar and spell check. Now they have added AI into it. So you can ask help from the generative AI. They have all these tools that can help you rewrite and rephrase and make it sound fluent or fix the mistakes. So AI will do it for you to save time, and probably they are writer better than us in native. This is another tool. You can have a look later. PayPal, it's called. This is an article about drafting the research. The issue here, it clearly needs human oversights. They mentioned in all stages till the final output. You cannot really agree on whatever they say and just post it there. And again, mentioned here, references provided by ChatGPT cannot be trusted, as we showed earlier. All these studies are saying the same. So, a lot of gaps. We mentioned most of them. You can read them later. And this is the huge, big part, actually, everybody now is talking about. And they have specialized people only in ethics related to AI. There are ethics in using AI to upload your data. Some of them you need to read the privacy and policy for each app you use. They might use your data for their own training, which has sometimes become unethical, especially if you are uploading unannotated data. So you're uploading the names and MRN for your patients. So it's really breach of security and a breach of privacy. The other thing is human oversights and transparency. Most of what we said are generating text from something they are trained on, we don't know what it is exactly. We don't know how well is the data was chosen to train these AI models. It might be garbage, and as you know, garbage in is garbage out. So you really need to take this into. So as a take-home message, AI can amplify human, but not replace them. AI plus human is the dream team. Consider AI as your superhero sidekick. So you can use them just to help you with anything. And tools that are increasingly in daily basis, use them with caution and assess their validity before you really depend on. The other part is innovate research. I'm not going to talk about it because it will take another 1 hour. So, but I want you to know that every study was mentioned yesterday, from using AI to help in doing echocardiogram, till using AI to do retinopathy exam, are all research idea and are all done using AI, and all can be done by physicians teaming up with experts in AI. So consider all of what mentioned as a research ideas in your field. Any gap you find in your field, any subjective thing you want to make it more objective, you can use AI into it. So it's a very useful thing. It has its own process. It's a different methodology. You might find it difficult to have an access to an AI expert guy. But if you need help, you have my email in the end. This is the last slide. One of the AI guys are hypothesizing this now, and he's working on. It will access all the charts for the patient. At the same time, it will access the literature. So it will compare your patient to the literature, and it will give you an output, and you can exchange with it information and ask it about your patients. And it can be applicable in all the aspects in healthcare. Thank you very much. You can access my slide through the barcode.
Thank you, Dr. Ahmed. Yes, for this really informative information about the artificial intelligence and evidence-based. So, Dr. Tamara, Dr. Omar, Dr. Ahmed, please be in the stage. Question, please. Any question?
Question for the last speaker. Perplexity is one of the AI tools that it claims that it can provide valid research references. What do you think of it?
Yeah, actually, Perplexity was proposed by one of my colleagues. I have used it once only. Again, it's one of the tools. If you will mention all the tools on the internet, you will not end in one day. So there are a lot. I tried to take the most commonly used one, and the one I tried myself and I saw that are really beneficial, let's say. So there's some bias of me here. But Perplexity, yes, is one of them. And you can see some free tools, some premium tools. So some of the ones I mentioned are premium, actually. So you might find accessing to them is a bit costly, but they have a trial for like 7 days, so you can try most of them your own. What's suitable for me might not be suitable for another one. So everyone has his own experience, I think.
Any question?
Good morning. I'm Dr. Helmi, pediatrician. I want to thank for that informative lecture, really. But what I want to clarify about accepting now the artificial intelligence tools, especially the ChatGPT, as a co-author in the researches, is it validated now or accepted to be co-author in the researches? Is it accepted now?
questions for me. So I could not hear you well, but your question was putting ChatGPT as a co-author.
Yes.
Okay, great. So I passed through this, and I was going to put it as a part of the ethics part, actually, in my slide. But now, during the last maybe 3 years, some of the researchers started to put ChatGPT as a co-author. But nowadays, most of the journals are seeing this really not acceptable, and they are advising the authors, not only advising, they are refusing the articles where you put ChatGPT as a co-author. But let's take it from another perspective. You should not put ChatGPT maybe as a co-author, but you should mention it in a part in your study, like in the methodology, where you used ChatGPT and what was it for, just as a declaration that you have used it. For me, let's say as an intensivist, if I read a study, I'm just hypothesizing here, if I read a study that the author wrote for me that he did, let's say that statistical analysis using a GPT or a generative AI model, whether ChatGPT or anything else, I will put a big question mark if he did not mention that this analysis was reviewed by a statistician. And I would not accept this article in my journal, for example, until I see that verification. So usually if you use some of these tools, I think it's better if it was a major part in your research, just mention it even in the acknowledgement or whatever, but not as a co-author.
So still not widely accepted.
Sorry?
So still not widely accepted.
Actually, as a co-author, it's rarely you see it accepted. And they were accepting it because there was no regulation regarding it. But now the regulation is becoming more apparent. And most of them are not accepting as a major co-author in your article.
Another thing you can, right now with ChatGPT, what you can do is you can actually do a quotation. So I would not use it as a co-author. But now there's a new feature in ChatGPT, at least ChatGPT 4, in which you can get a quotation. You actually, as if you're quoting a research study. So you can actually, after the generation of that ChatGPT message, you can add that quotation and just put it as like you're putting it off some other research. So you can actually get a link to that conversation. So in the end, there's something that says quotation. You can actually quote that, like as if you're quoting any research study.
Last question.
Thank you so much. Very interesting talk from all the speakers. There's another tool used by publishers to catch plagiarism. You did not touch upon that one. Can you just elaborate for the audience what this software tool does?
Yeah, softwares for plagiarism actually are very not new, and they're existing for a long time now. And now AI is getting into that. Let's say that Grammarly per se, when I mentioned the Grammarly, they have a tool for plagiarism, which is a very nice one. Now they are integrating AI into plagiarism check. Now, most of the things that I mentioned for co-writing, like ChatGPT and the other apps, sorry, not ChatGPT, I mean Grammarly, Paperpal, and Perplexity, I think also has this. They have a plagiarism check. But AI rule into that is still fake. It can be done without AI. But they are integrating it with AI to make it better.
And that's what universities and I think a lot of like schools use, right? So they
have
use
special
that
softwares for plagiarism check, but these softwares are not necessarily AI.
One question from Dr. Ammar.
Thank you very much, all speaker. I have one question for Dr. Umar. Regarding the evidence-based neonatology, it's a very wonderful community, I would say, through the social media, the website, especially the article of the month, the article of the year. Being a neonatologist, this is very, very nice, I would say, a group of people doing a great effort, but it is very beneficial. Unfortunately, I noticed some of the neonatologists, they will apply that article immediately because it's mentioned in the evidence-based neonatology. What's your comment regarding this, without doing the critical appraisal and?
I think this is a universal problem, not really confined to neonatology. And whether you get your new paper from social media or from PubMed, the rush to implement the evidence into practice is another problem, you know? So it's not really due to the dissemination of knowledge that we are doing is because clinicians are sometimes, have the urge to do something different. And this is wrong. This is a wrong practice. And honestly, even a very good RCT that comes out should not immediately change your practice. You need to see a systematic review or a meta-analysis or at least a few RCTs that's confirming the same kind of outcome. And then you start. But the evidence practice gap, at the moment, it takes several years. So we are talking about 17 years, So we don't want the immediate action, but also we don't want the too much or delayed action. We want some, a reasonable kind of approach to, زي حتى في الدين نفسه في الحديث النبوي ما تقدر تاخد حديث واحد وتطبقه مباشرة. تبغى لك عالم يجمع لك الأحاديث يقول لك هذا له سياق وهذا له سياق and so on. Same with the medical literature, right? This is an RCT, it's a good RCT, but it has its own context. The patient population demographics are different than your own patient demographics and so on. So we have to be reasonable, and this is really a very good topic to discuss on how to slow down your actions and your treatment and management. So thank you for your question.
Thank you for all the speakers. Now you can scan the code for the short quiz, and it is appreciation time. Dr. Tamara, thank you. دكتور عمر. دكتور أحمد. دكتور محمد.
Now we'll take the short break and we will continue after the break inshallah. 10 minutes inshallah.
2 minutes.
2 minutes, okay.
Or you prefer to postpone the break after the workshop? I think it will be better. Let us start with the workshop. 2 minutes عشان الدكتورة أمل يلا 2 minutes. Forget to announce the winner for the quiz. Sorry for that. The winner is دكتورة وديعة. دكتورة وديعة الحكيم. She's the winner. She's the fastest one. Come, دكتورة وديعة. الله يعطيك العافية. أسرع وحدة بلا منافس. نبي نعطي واحد منكم. انت جبت بس بالاخير كنت جبت ثلاثة صح. بس وقف 2-3.
عشان نروح لللانش عشان نروح
We will start now the last part of our conference. We will have 2 workshops. Each one will last like 35 to 40 minutes. We'll start the first one with Dr. Ahmed Hilmi. Dr. Ahmed, he is a pediatric specialist in AlHasa Specialist Hospital. Dr. Hilmi, he obtained his bachelor degree from Faculty of Medicine, Al-Azhar University. Then he completed his residency in Pediatric at the same hospital, and he had a master degree in Pediatric also from the same university. Dr. Ahmed will give us a workshop, and he will give us a talk about the practical perspective of using the artificial intelligence. I know Dr. Hilmi, and I'm sure he will give us a wonderful workshop today. You can start, Dr. Ahmed.
The organizing committee, especially Dr. Amay and Dr. Ammar, really they did great effort. They really, and also I want to thank all the speakers, because really we get too much benefit from their lectures, especially the last lecture of Dr. Ahmed Al Khalifa. Really, I get too much benefit from that lecture. First of all, I want to explain that my lecture will conclude what we spoke yesterday and today. Especially our colleagues went deep in the details, especially the subspecialties like genetics and so on. So my target in that lecture, not to go too much deep about artificial intelligence and subspecialties. I know that our audience, many of them has too much experience about technology and went deep in artificial intelligence, but some still. So my target, I want to explore how to use it, maybe for beginners, or also for who already have some experience about it. Especially, I want to check how to use, explore how to use the artificial intelligence with premium users which have access to customized tools in ChatGPT, because ChatGPT itself, we have to use it very cautiously. Especially as we see in the previous lecture, they are mentioned a very important part, that there is too much limitation of using it. So it is good, it is wonderful, but still we have to use it in the right way. So how to do it, what I want to show our colleagues how to use it without making too much mistakes of using it. So now I will go not too much deep, but I want to speak in general about the artificial intelligence and some impacts on the medicine, especially pediatrics. First of all, I have nothing to disclose. I will not go deep in that part, but of course I have to mention that the artificial intelligence is a branch of computer science that aim to create machines capable of intelligence behavior, mimicking cognitive functions like learning and problem solving. As regards the functional aspect, AI systems perform tasks that typically require human intelligence, including pattern recognition, decision making, and language understanding. The AI really transitioned from basic algorithms to advanced deep learning, enhancing pattern recognition and predictive analytics. And as we spoke before, it started from just algorithms, but now we reach to the deep learning, which actually will make difference in the result or the output given to us. For each patient, really, it will make difference and save time and save efforts for more care to the patient. Also, as regards the ethical framework, when we hear about the artificial intelligence, all of us are happy that we will get some help, but still we have to take care of that part, because the privacy and the ethical part is still not clear about using of artificial intelligence in general, and it's tool like ChatGPT and so on. So we have to, as mentioned in the previous lecture, we have to read the policy and know policy of privacy for each tool we are using, because maybe there is something will breach the privacy of some of our patients, and really we have to take care of that part. So the progress in AI matched by increased attention to ethics and the development of regulatory standards for its use in medicine. We will explore some, like recap what we mentioned before, that the AI really will make too much improvement in precision diagnostic. It will improve the accuracy and efficiency in diagnostic pediatric conditions, leading to early intervention, and what I want to stress on, the personalized treatment. Really, it will suggest a tailored treatment plan based on individual patient characteristics and medical therapy, and also that individualized care. Maybe the terms similar, but there is difference. The personalized treatment related more to the medical treatment, but the individualized care related to the broad term for the patient care as regards medical treatment, and maybe also the observation and other aspects of patient care. Let us to explore some impacts. What happened really, how the artificial intelligence, by examples, improve some aspects of pediatric practice. Like at the Center of Cancer of Blood Disorder in Texas, clinical artificial intelligence is used to predict which patient care likely to require emergency care within the next 30 days. And actually, it was a wonderful result. By taking predictive measures, oncologists have managed to keep patients stable and out of emergency room, saving an estimated about, according to them, $3 million. Also, AI ability to analyze genetic data has enabled oncologists to identify mutations that make cancer more vulnerable to immunotherapy. This helps in selecting the most effective treatment strategies, predicting potential side effects, and avoiding adverse reaction, leading to more effective and, as we mentioned before, personalized patient care. AI-driven robotic surgery also, like the Vinci system, which mentioned them, has improved surgical planning and execution, particularly in minimally invasive surgery, leading to enhanced patient outcome and reduced healthcare costs. Also, in artificial intelligence, the other benefits may be mentioned, that AI-powered tools enhance healthcare by offering data-driven insights for accurate, informed decision-making in patient care. Also in monitoring system, as we saw yesterday in the, by our neonatologist, which mentioned that maybe the follow-up of the heart rate may affect the outcome, as we will see now in one study. It may affect the monitoring system integration in our patient care, may help patient management, enabling proactive care. As we saw yesterday, that may predict the sepsis maybe more than 1 day before the patient become critical, and as a neonatologist, we know that will make too much difference in the outcome. Patient safety and error reduction also contribute to safer healthcare practices by identifying potential risk and reducing errors. Also in the prediction, we have lecture about it and also its impact on data mining and pattern recognition. We will see, we will apply now how can from one research and data of the patient, we may have hundreds of thoughts of researches we can do, and it will, by analyzing of that data, we will have more thoughts about more researches to be done. So also accelerating medical breakthroughs and understanding pediatric disease, it will make difference in it. More also about inspiring examples of impact on real world AI implementation in pediatric care. There is one example that AI model accuracy segment glioblastoma tumors in children and improving treatment planning and patient outcome. Also the deep learning and informed yesterday explained what's the meaning of deep learning, which is learning of the machine and giving them data, so it will improve the outcome of the patient care and understanding their pathologies. It enhances the personalized radiation therapy in Cleveland Clinic, uses an AI deep profiler to predict radiotherapy outcome from lung cancer patient CT scan. Also, there is also one study about the sepsis, and we mentioned that yesterday. Really, it was amazing, and as I told, really, it will make too much difference to predict or to catch the sepsis before the patient is fully symptomatic. And really, not only 6 hours make difference in our practice, maybe 30 minutes may make difference. So really, it will be, and the outcome really, it was amazing at reducing mortality rate from sepsis estimate to have saved 282 lives. And really, it enough to save one life to acknowledge its benefit. Also, alert clinician to sepsis warning signs, enabling, of course, prompt intervention. Also, there is one example very good about pediatric asthma prediction, especially the exacerbation. It was that study. It was in the Mayo Clinic, and it enhanced the medication adherence using the artificial intelligence by what we are calling virtual direct observed therapy, which are direct if the patient is about to develop exacerbation, directly observing them at home, so it directing their treatment without coming to the emergency. So it will be amazing to decrease the burden on the ER. Predictive asthma management guidance and the prediction system predict future asthma exacerbation, enabling early intervention. Increased efficiency in care, clinicians spend less time reviewing electronic health records, leading to more efficient patient care. And we will see now how it may save time, and maybe mentioned in the previous lecture, how much it may save time if we use it in the right way. Also, the artificial intelligence enable accurate monitoring and the predictive analytics, significantly improving asthma management outcome. AI innovations in pediatric care, example also that maybe in one hospital, in Phoenix Children's Hospital in USA, it catch some patients missed by the clinician. And that patient have some form of malnutrition, and it was presented by the executive CEO by and Chief Innovation Officer at HIMSS 2023. It as per him, he developed an advanced artificial intelligence algorithm utilizing 25 years of patient data and integration into electronic health record handled identifying 6 to 10 undiagnosed malnutrition cases weekly. As that market improvement in early detection and treatment of malnutrition, it was within pediatric age group. So as we saw, too much improvement in the outcome in the patient care, but as we mentioned before, there is ethical implication of AI in pediatrics as regards privacy and human judgment and insights, and that's too much important because actually we cannot leave the artificial intelligence work alone. It will not replace the doctor. Of course, the patient insight is the too much important part. It should just complement, not replace human judgment in pediatric, blending medical expertise with algorithmic insight for optimal patient care. Also that what we mentioned before, and we want to stress on that part, that the ethical guidelines and policies to responsibly utilize AI in pediatric care, we need comprehensive ethical guidelines, which still, I think, not well developed, that dictate its fair and beneficial use. So that limitation also, other than the ethical part, the data quality. We mentioned many times, if you give him garbage, he will give you garbage. And the need of a human oversight, again and again, human oversight, because sometimes it gives wrong result. So we have to review what they are giving us, maintaining ethical standards. As regards the healthcare professional training, which what we want to do in our workshop today, we want to divide that part in two parts. There is daily task for physician. We can use the popular tools of artificial intelligence like ChatGPT and the customized premium GPTs, and also the artificial intelligence application at the level of the hospital. There is difference. The artificial intelligence is specialized in specific specialties. It is utilized by the hospital, and the artificial intelligence should be adopted by the hospital to be integrated in the system in the hospital. That part we cannot speak about it as a hands-on training, but the part we will try to explore some function of it. The popular tools we are using, we are using every day, like ChatGPT and the customized tools that like what we will see now. But what we mean in that slide, that training in the AI will help really the physician in if we did that part in collaboration with AI experts. As partnering with AI specialists can propel the effective deployment of AI technology in pediatric healthcare, seamless integration into workflow, and also it needs really too much training because the clinician actually is not AI expert, so it needs training in that part to can integrate it in their workflow, and it will need time. Efficient integration of AI system into healthcare routines is essential for maximizing their benefit in daily patient care. Continued learning and development. Healthcare professionals need to embrace AI and foster continuous learning to keep pace with this rapidly evolving field. That also the future of AI in pediatrics, really it will help in precision medicine. Like Dr. Ahmed mentioned, we are waiting for ChatGPT 5 with the time, and that's the problem now. Every day there is a change. Every day there is new application. There is new advancement. So it's mandatory to follow, to be followed by the physician. Also, collaborative research and development and transforming, and it will transform the healthcare, of course, as we see from the previous lectures. So the conclusion that embracing the power of AI in pediatrics, first of all, the professional training in the AI. Also, the AI future in the pediatric has potential to transform pediatric care by enabling precision medicine. Also, we came now to the last part of the that lecture, that practical hands-on session, because we know all of us is a busy physicians. So it's very difficult to do all your tasks today. All of us, I think, have the problem with that. We have to do usually the patient care, and also we have to learn continuously. So the popular the tools which in our hands now may help us in some way. A few examples of that: rapid book summarization and also video summaries. Now, I think maybe some of you know that or no, we can, if we have long lecture, maybe whole conference, we can capture its link and put in some tools, as we will see now in ChatGPT. It will help you to get the summary of all the video. So it will be helpful too much to save time. Also simplification, that's too much important, especially the ChatGPT. ChatGPT is not specialized, but actually it simplifies sometimes. And sometimes I'm not specialized in some subspecialty. So if any tool simplify for me that part, I will catch from it what can I get the benefit from that part in my career or in my specialty. So it may be helpful in that part. Also efficient data analysis, but that for customized tools, we will see it now in ChatGPT. So sometimes it will help you in data analysis, especially for whom that not specialized. Also, as regard workflow enhancement, of course, sometimes you may use that tools in helping the patients or giving instructions for the patient in simple way. You now not need too much time to prepare it for them. For now, I want to, before we go to some practical parts, I want to tell our colleagues how to utilize that skills and how to maximizing AI utility. There is, from my opinion, there is 8 essential skills for physicians using ChatGPT and similar tools. First of all, to understand the capability of that tool, because he can do something and some things cannot do. So it's too much important. Don't imagine that he will do everything for you. Impossible, of course. So if you know what the limitation of the tool you are using, it will be too much helpful. Also, effective prompting. Now we have what they are calling prompt engineering. The prompt is really is the drive which let you to direct the application, the ChatGPT. So if you direct them wrongly, it will give you wrong data, of course. So we'll see some difference now, how the prompt make difference in the outcome. Also, to maximize utility from the artificial intelligence tools, which is too much now, continuous learning, because every day, really, now every day there is a change. So you have to follow that. At least now, using the same artificial intelligence tool, you can ask them, what's new about that? What is the difference between what happened and what's going now? So really you have to follow that. Otherwise, you will be left backward. Also, integration, try to integrate it in your clinical workflow. Don't tell that I used to do that, I will not change. Of course, it will let you in the back. Critical evaluation of AI response. That's too much to maximize your utility from the AI, because you have to follow what they are giving to you, not to take it for granted that it is 100% accurate. Of course, you will do mistakes. You have to oversight. You have to follow what they are giving to you. Is it accurate? If you ask him to summarize something for you, you have to review it again. That's too much important to be done. Also, for utilizing it for research and keeping updated, of course, Dr. Ahmed covered that in detail. But you have to know that it will help you too much, not the ChatGPT itself, different specialized artificial intelligence tool, so you can use it instead of waste of time. Customization and personalization. What I want to speak today and also show to our colleagues that for the premium account on ChatGPT, you can generate your GPT. imagine that you are summarize the books, and also you want to get a specific summary for some part of the book. You are interested only in the investigation. You are interested in the treatment only. You want to extract what's related to the treatment in whole the disease mentioned in that book. So you can upload that PDF on that customized tool. You are the one who make it by yourself, and it will help you in the way you want. You will tailor that tool for the target you are using it for it. So imagine that you want only to make difference between guidelines about like pediatric asthma, and you have file for the American Academy of Pediatric guidelines for asthma and Saudi one and whatever. So you want to catch the difference. You have no time to read one by one. So you can just upload them on that tool and then ask them, please catch for me the difference between them. It will help you in that. And also you can interact with the PDF. So if you interact with the PDF, maybe some missing also, you will catch it. So it will help you too much to catch the difference. So that automated content extraction, it will help you too much to make summary, to learn time efficiently, to interact, as we mentioned, with the PDF. So as we mentioned, if you interact with your resources, it will be helpful, because sometimes also maybe we know all what mentioned in that article, but sometimes there is one word, two words, instead to go to the Google and you just read it, type it again, and then search about the meaning. You can just ask one question, like if you have colleague more expert than you in that topic, so it will help you to get the answer very rapidly. It will be really amazing, especially if you have no time. Also, the benefits of effective prompting for physician using ChatGPT, it is the most important part, how to prompt it, because many of our colleagues, when start to use it for the first time, they will find it very difficult. What's that? I'm giving them something and he is giving me another thing. Actually, that's because of your prompt. Because if you prompt the tool in wrong way, it will give you totally different answer. So the benefit of effective prompting for physician, it will customize the information given to you. It will give you what you want, and it will reduce the misunderstanding, because if you give clear prompt, it will minimize the risk of misunderstanding or irrelevant response, as we mentioned, and also it will optimize the resource for you and will, of course, add to the educational value. So let us take example how different prompts affect the response. If we want to do in-depth analysis for some section, like if you provide detailed summary of the section of insulin therapy in type 2 diabetes from the diabetes management book. Maybe the possible response that the insulin therapy in the book delve into when and how the initiated insulin therapy in type 2 diabetes patient. It will discuss different type of insulin dosing strategies and how to adjust those and so on. But if the prompt like that, compare the treatment approaches in chapter 3 and chapter 7 of the diabetic book, it will give you different, of course, totally different response, and the comparison will highlight the progression from basic oral medication to more advanced technology, and will delete all what you don't want to read about it. So that's the part we will see in the practical. We'll see some hints about it. So, but what I want to tell our colleagues, you can design your GPT if you want to do a specific task and you want to be specialized in some way. So it will tailored medical insight, get precise, age-specific medical information and treatment options. If you have like literature speaking about diabetes, you can catch from it. You can tell that GPT to just catch what's related to the pediatrics in that literature. Of course, instead, maybe some articles, maybe tens of pages. But if you ask them to just catch what is for pediatrics, it will make difference. Also, streamlined research, quick access summaries of pediatric studies and development. It will enhance patient education. If you design GPT for patient education, if you design GPT tool and ask them, if I have patient and I give you your data, please give me education tailored to the patient in such way, and you tell him to give me in Arabic and to be in popular words. It will, instead of you search about all of that, just give him the case. Every time you just give him the case, copy paste, and he will give you the instruction written in the language the patient wants, without to waste time in that part. Also, it may help the doctors in the efficient documentation. If you have like a template, you like to see all your documentation in that way. So just give the patient, give that GPT tool what's the update every day. So it will give you all the progress note of the patient without you write any word other than the updates of today. Of course, that may help save hours for the physicians. Also, diagnostic assistance maybe help you to build, if you upload like our textbook, our common textbook, like in the pediatric, like Nelson, like guidelines, American Academy of Pediatric guidelines, and then give him one case you face in your clinic. We'll give you what is the related guidelines about that part. We'll extract it from the literature and give you the suggested differential diagnosis. So it will help too much. So before we go to the practical part, to see how to customize artificial intelligence tool and so on, I want to give last message to take care when you are using artificial intelligence. Beware of misinformation. That's too much. Always verify AI-generated information, as it may occasionally be incorrect. Critical assessment needed. Evaluate the AI-provided information carefully. It is a tool, not an infallible source. Patient care enhancement. Utilizing AI, it will support, not replace your patient care efforts. It is there to assist, not to overtake. Daily task assistant. It will leverage AI to manage routine tasks more effectively, but maintain a balance with personal clinical judgment. So now we'll go to the practical part. Why not?
ثواني بس عشان
ممكن نروح دلوقتي اتصل So now that is the ChatGPT website, the premium version, and here that ChatGPT 4. Okay, if you access that site, take care, because sometimes many colleagues told me that they are accessing the website and try to search too much, and finally they didn't get anything. Actually, when I check what did they do, I found them, they just are paging the ChatGPT using ChatGPT 3.5. So that's too much important to choose ChatGPT, not 3.5, 4. And then that is the first page you will see when you access the site. And as you know, that it chat, so you can tell him what you want, whatever you want in that part. In that part, whatever you want. But what I want to mention, to save time, that also there is customized GPTs. That's what I want to show our colleagues. that customized GPT, it is more specialized than ChatGPT itself. It is customized by a more advanced developer, so they make it what actually want to do exactly. So we take, let us to take some examples. Maybe that that customized tool, which named effortless book summary, how to get it again, to repeat, access the site, explore GPTs, and from here, from that search part, you can write whatever you want. So like I usually, I am exploring the new customized tool to can get save time to summarize book and so on. And I choose that customized tool. And I use that tool, like if I show you example, I have one. If we take that PDF file and we ask him, please summarize the content. What I did, just I access that tool, customized tool, and I upload the file. So suppose that he will, as you see, I think that it was more than 10 pages, or I'm not sure, but it's too much. That is a summary. You can imagine. Of course, like we mentioned, you have to review. But sometimes, if you read the book already, and you want actually to review it, and you know what's written, but you want to save time, so just upload that one, and you will give you, if you want to make it more concise, it will give you more concise summary. He is asking you, are you sure? And then he is preparing it now. If you want it also less concise, you see that he deleted too much important information for you. You can ask him, please let it to be less concise. If you want to ask him question, maybe you have assignment about, as you see, it make it less concise, give you more information. Sometimes you like your data to be presented to you in some form, maybe complete just a paragraph. Part of us want it in bullet points and titles. You can tell him, please, can you make it in one paragraph? You can tell also, please, can you make in bullet points and titles? So you are the one who direct the response. It is too much examples. Actually, the time is too much little for that. But I want to make the prompt. I want to show that prompting make too much difference for retrieving the data. Also, if we want to go to the summarizer of the videos, just if you want also to explore the other customized tools to show you more easy or more friendly to use tools, you can just write summarize. He will give you too much examples. I don't know if we can access YouTube from here or not, but you can choose that YouTube summarizer. It will open another tool for you, and what only you want. I don't know if we can access YouTube from here. No medical video. Maybe like pediatric, asthma, or whatever. And you will take that video. We don't want the voice. I will go to share and will just copy that text, our link, and we'll go to that summarizer and suppose to give you that he ask you for privacy first, allow, and then he will watch the video and then give you, as you see now, what's the content on the video in less than 1 minute. So actually it will be helpful. Sometimes actually we have no 1 minute, not 1 hour to watch lecture. So it will be helpful. Sometimes you get that data and you discover that you are not in need to read all of that. Maybe if you watch it, you will regret that you give time for that lecture. So it may sometimes summarize the lecture for you, may give idea. If you found it too much, you can tell that's too much. Actually, I want more summarized. So it's like I'm trying to give as much as the time will be allowed for me. It's too much examples for that. What also is too much important, in my opinion, documentation for the physicians. Actually, all of us have problem. I want to go to that part now. With the time for documentation. As I mentioned in the presentation, I can design my GPT. As I mentioned before, I went to the website, I went to the Explore GPTs, and then I went to create. Then here's the GPT Builder. What's the meaning of GPT Builder? GPT Builder means that if I want to configure a specific tool for me, for my daily task, like if I am doing every day summary for books, I'm a student or whatever, or if I am solving exams, or if I am documenting data of the patient, or whatever I want, I can configure. I will go to that feature, configure, and then I will give it any name, like Summarizer Pro or whatever.
5 minutes, Dr. Ahmed.
Okay. And then I will write description, what actually I want from that tool, like summarize any text in bullet points. I'm just giving an example. Of course, your prompt should be more specified than that. And then I can also give him more information. That's what we are repeating yesterday and today, training. That I'm training now the tool. I'm giving the tool what I want. And also, finally, I can upload files here. If I don't like to write too much, I can upload file with a specific prompt I'm using, or a specific data, or data of the patient. I can upload from here, and then finally, I can create. After I fill all of that, create icon will be active, and then you will give me here in the other side, like you see, a chatbot. So I can use that. I build the application. I can use it now. He will follow your order, and you can still training. You can change every day what you like, and you can check the outcome, the output. And if you still find it's not stick to or giving you what you want, you can add another prompt and so on. So finally, you will get what you want after you train the tool and get what you want, and you can save it finally. From here, if you save it, it will be, maybe you can, if you want to share with others, for everyone, as you like, and then you confirm. It will be finally, if you go to the Explore GPT again, you will find my GPTs. Every time you access the site, you will find it as the first icon you see, Summarizer Pro. So you can use it in your task daily. So that's just example of how can you access or use customized, or you customize by yourself, design by yourself GPT tool to do what you want exactly and how to train it. Finally, I hope that my presentation and my hand-on training helped you. And of course, that not the time is too much restricted, but my target to give you just idea about how to use artificial intelligence tool and especially that ChatGPT. Thank you.
Thank you very much, Dr. Ahmed, for the valuable insight and practical perspective on using the artificial intelligence. Now we'll go for the last workshop of the day and in the conference. It will be about using technology with the speech, language, and swallowing patient. Will be presented by Afnan Al-Jamal and Fatma Al-Baghli. Afnan is a speech and swallowing specialist in AlHasa Specialist Hospital. Afnan is a holder of bachelor degree in hearing impairment from King Faisal University and master degree in speech pathology from University of Jordan. Fatma, also she is a speech, language, and hearing disorder associate in AlHasa Rehabilitation Hospital. Fatma obtained her bachelor degree in science and speech pathology and audiology from King Saud University. Then she continued her study to obtain her master degree of science in communication disorder from North Carolina University. Welcome, Afnan. I think we'll start with Afnan, then Fatma.
Assalamu alaikum everyone. My name is Afnan Al-Jamal. I'm speech and swallowing specialist from Musa Hospital. It's my pleasure to participate with you today in this conference to reflect our clinical experience by using technology with our patient at the hospital. So today I will focus more with using technology with the dysphagia patients, and I just will give you some review or some information about the history that we use the technology before with this kind of patient. So this is the contents. And usually when we are talking about speech, language, and swallowing, we are talking about our communication system. And this is which reflects our communication needs by using our language. And when we are talking also about our communication system, that reflects the oral and pharyngeal mechanism that we need for swallowing and feeding. So there is any history related using the technology and the tools or assistive devices to diagnose patients with dysphagia before? Yes, absolutely. We have many of SLBs. They started by using the technology with the patients since 19th century by using the fibrotic endoscopic evaluation for swallowing, which most common with the ENT doctor in their clinic. So they were used with to assess the voice, to assess the voice mechanism for the patient. So, but we are also use it at SLB to assess the dysphagia patient. Also, we have the combination between technology and radiological components to have the fluoroscopy study that give us to assess the functional of the use. To assess the oral and pharyngeal fees. This is only history that we have. So also we have the communication, the assistive devices that we use for the patient with special needs by using specific boards since many years ago. And we can see that some blind people, before they have their portable device and to use it, specific buttons, tactile buttons, and nowadays they are used in advanced level with some technological features. Also, we have the AAC, maybe all of you have this AAC apps, and also the starters were with the patient with the special needs. Maybe it started as picture exchange, then move to have it in more portable devices. So, how about the COVID-19 experience with our patient when we are using the telehealth practice and different apps with them? It was actually really great experience with them because we are seeing the progress with the patient when we are using different kind of apps, Zoom, Skype, but even there is some limitations, but we have been used it with the language disorder patients, voice disorder patients, patients with hearing aids, and CI patients. So all of them, they get benefits from this kind of telehealth practice and these devices or these apps in that time. So just as the doctor mentioned before, that we have to just to focus how to use this kind of application with our kids, and we should just to target. We cannot give them this application without target anything with them. So we should to target and make time management. And this application doesn't replace our role as a specialist in this area or their roles as a parents. So we'll start now what we are using as a swallowing specialist now in AlHasa hospital or in our scope, what kind of examination or assistive and technological examination we are using. So for dysphagia patient, for pediatric or adults, we are using this kind of technology, this combined between radiological components and technology to assess the swallow function. So maybe it's very common, or sometimes it's not common to you that to know or to hear about the fluoroscopy examination. Also, we call it sometimes barium swallow or upper GI examination. So the main goal of this examination, or how it helps us, this technology, to make. We wanted to say that it's helped us to make the good treatment plan with the patient, to diagnose them, and to avoid any risk for oral intake with these patients. So this is the main purpose. The main purpose is not to rule out the aspiration with the patient who are MPO or under tube feeding, but this technology helps us to, as I mentioned before, help us to understand our patients better, so we can diagnose them perfectly and avoid or suspect the risk for this patient for oral intake in future. Disadvantage of this technology, the radiation exposure, some consultations, and maybe we cannot take the patient if he doesn't have the oral acceptance to go to the, if he doesn't have the oral acceptance to take something by the mouth, to take the patient to do this type of examination. So, what else? What we have more? Actually, we have pharyngeal also manometry. Pharyngeal manometry, it's new tools and trendy tools now used to assess the patient with dysphagia. So it's combined also with the fluoroscopy. It's assess the pressure for the anatomy for the anatomy or the structure for the swallowing. So sometimes the SLBs or the swallowing specialists use this tools also combined with the fluoroscopic examination. So it uses sensor to assess the pressure inside the structure of the pharynx, then can decide by this technology, understand what is the weaknesses exactly with this patient, and to target it in the intervention. So also, sorry. أنا برجع بس ما عرفت. Okay. About the video fluoroscopy, I missed one point, that now we have software vision from this exam. So you can some hospitals buy CDs. So they put the CDs in the system, and this is the advanced vision from the field fluoroscopy. So just they combine between your results as a specialist and give normative data and quantitative data and about the patient and his dysphagia level. So, okay. So what about the intervention? Usually we use the intervention. We use some, absolutely, after the assessment by using our assistive devices, we have to intervene with our patient, and technology help us in this part by give us the opportunity to use the neuromuscular electrical stimulation. Neuromuscular electrical stimulation, it's a trendy use, and it was discovered since many years ago, but nowadays most popular, most usable by the SLBs or the swallowing specialists. So the main idea or the main concept for this device to re-educate the brain about the muscles, to innervate the muscles again and increase the strengthening of this muscle. So this device you can combine with this device or this technology, we can combine it with the manual therapy, and actually it's evidence-based, and many of our patients in a clinical practice get benefits from this device. So actually it has some electrodes, and we do the placement with the patient starting from the baseline, and we usually get benefit from this device, the pediatric and infant patients. So we cannot do proper manual therapy with the patient, so the neuromuscular is one of our solutions. So how about the oral motor placement therapy? This is the second kind of therapy with or the intervention procedure we can use with the patients as assistive tools and technology help us. It's usually focused with the patient who has oral dysphagia and patient who has feeding issues. So they are many of companies create specific tools that they can use it to inside. You can use it inside the oral and oral cavity and out your oral cavity to enhance the swallow function for the patient, for the feeding issues, patient with the poor lip sealing, or patient who cannot manage his saliva. So the other things that I wanted to talk about, the AMC, it's one of our also the new things that we are using, and it's very effective with the patients who has dysphagia or pediatric dysphagia, adult dysphagia. So these tools help us to make swallow breathing coordination, because it's make resistance for the muscles. So many of our patients get benefits from this device because they decrease the secretion, protect the airway more, and squeezing the bolus from the pharynx, and help the patient to maintain his functional oral function or the oral interpharyngeal function. So. Okay, this is I put some of our case studies that get benefit from this assessment and assessment procedure and intervention procedure with this kind of devices. So actually, the first case, in this case, CB and post surgery, he has 2 episodes of aspiration pneumonia. So this is the cam of the need of the instrumental examination or this technology modified barium swallow to assess the patient. Patient doesn't give us any indications for swallowing difficulties. Maybe he has delayed, he has oral weakness, but he doesn't have any aspiration indication in bedside assessment. But this exam or this technology help us to find the patient who are silent aspirator. So patient after the exam, after we see the exam, patient was aspirated and take liquids, and he doesn't try to eject the fluids. And this is, as I mentioned before, this technology how to help us to understand our patient and how to manage him and manage the treatment plan, target what we wanted to do with the patients. This is my case. So absolutely we hold the oral feeding, and even he is he doesn't aspirate in other constancies, but he was at risk because he is silent aspirator. Nothing indicated in the bedside assessment that he was aspirate. So I don't want us to take a long time, but I wanted to finalize with the other patients. When I was this is Down syndrome patient. I saw him when I did my master degree. So we work as a team. He has poor oral skills, pharyngeal dysphagia, MPO since that long time. So we try with our consultants, we check the patient for this instrumental evaluation, and we find the patient was aspirated on all the constancy. So we understand what is the weakness, pharyngeal weakness with this case, and understand the physiology better, because as I told you, this tools help us to understand our patient physiologically, not only to rule out the aspiration. So we understand what is the weakness, so we try to start with him swallowing by swallowing intervention by using these tools that I told you before about, and then we reassess the patient again after intervention. He was aspirated again. Then after taking more time with the patient and increasing the oral function by using these devices and these tools with the patient, we decide again to take the patient for the evaluation. So after we see the patient doesn't reveal any aspiration, so we start with him to take the patient to take orally with the beauty diet under supervision. So this is the main concept. Sorry, this is my main concept about our use of technology and assistive devices with the patient, how it helps us to resolve the to establish our treatment plan and to make the differential diagnosis. Thank you. I finish.
Assalamu alaikum. Good morning or good afternoon, everyone. My name is Fatma. I will talk today about the AAC, which is Assistive Augmentative Devices for Speech. I know this morning was so long, heavy information, so it won't be long. I'll be so fast. So we'll start to define the communication disorders or severe and complex communication disorders rights, and for the communication children and disability, and what is the compensation and communicative communication. So this is a definition from AlHasa, American Speech Language Hearing Association. It's impairment, the ability to receive, send, process, it's any kind of communication disability. I can't communicate with you, so I have communication disorder. Complex communication disorder is if the child or the person have 2 or more of communication disability. So we can summarize it if the patient can speak but can't understand or express their feelings, patient can't hear or can't see, patient with cerebral palsy or Down syndrome or autism. These are all complex communication needs. examples of essential skills: understanding reading, speaking, writing, in addition to using grammar, spelling, and punctuations. So if the patient can or have language but can't use it with you, so this is communication disorder. I have the language in my brain, but I can't express my feeling. Or I have the language here, but I can't hear what you're saying. Also, this is complex. These are statistics of people with disabilities in Kingdom or 2017. So you can see all the numbers are high. Most of these children needs communication, like needs speech therapy or communication devices. ليش الشاشة اللي هنا ما تشتغل؟ لا ما تشتغل. So this is recent rights from the AlHasa. What's the rights for communication disorder person or people? So in summary, all the people have the right to communicate. Whoever or whatever they communicate, they have the right. And we have to advocate for them. What is AAC? AAC, we have high-tech and low-tech, so we can provide for the patients any kind of communication they are lacking. Whether we're using high technology or low technology, sometimes we use cards, sometimes we use iPads, or any kind of any way to help them communicate and express their feelings to the other person. This is the situation and the places where AAC is used with children with AAC, adults with AAC in home, and we have here recorded by family and self-reported. We can see in home is the most places with kids and in school also, but in other places, adult is using more than kids. And here's the benefit and improvements after using the AAC. You can see the dark color is significant improvement. So, what are examples of AAC? When I say AAC, what would you think of? Do you have any answer? If I said we have a device to help child to communicate, what is the first thing to come in your mind? Anything. Anything else? So there are different devices, different companies to improve the communication. We have eye gaze devices, so the patient can just stare at the screen and they can read, they can generate a sentence, they can express their feelings, they can just look at the letters and generate a sentence, just talk. And those devices can speak also in Arabic or English or any other language. So we have touch screen assistive devices, internet browsing by eye tracking or eye gaze, full computer control and eye play, so they can even play Roblox or any kind of the games you mentioned earlier, but by eye gazing. Expressing needs and expressing with eye gaze, so they can participate in school using those devices. If the teacher can had training before how to use this device with a kid, they can just use it so easy. And we have a company here in Saudi Arabia, it's called AlHasa. they can provide all these devices. هذه مو دعاية ترى يعني. It's the only company that provide those devices with a full package, with the like maintenance and the device and the training. They can come even here to the hospital and take appointments with the kids they need, and they evaluate and provide the devices and train the parents, train the specialists how to deal with it, and they can just give them maintenance, and it's a great company. These are some apps we use also in the clinic as assistive. These are books or stories application I usually use with the kids. It's more affordable than actual books. I do like actual books though. I have a small company for children books just to provide it for the kids, but I use this in a clinic also because it has, I can target exactly what I need. You can see here, it's about feelings, about family, about religion, so you can just choose what do the kids need or what or the mother need in home. What are the behaviors we're talking about here, and just read the story. And some of the applications has, like this one, Tuta, has even a summary for the parents, how to deal with the kid, or what the benefit from this story, why you're reading this story. So it's just so helpful for the parents. Also, this articulation station, I know it's in English, but we use it in the clinic for some of the sounds we have in common, like mim, ba, dal, sa, and za. It's just to help visualize. It has some visualization for the kids how to pronounce the sound. And now I will show you some one application that we use an assistive device. And it's for anyone can't generate speech. Anyone have no sound for any reason. So this is sound for them. It has a lot of languages. It has pretty good Arabic here. I didn't try the speaking part because this is just the light. I have to pay. But it's great. My friends tried it many times. So the patient can generate any kind of sentence. It has a lot. You can add anything you want. You can add pictures of the family. You can personalize it to the patient's needs. So if we want to try here, it can say anything, any word. You can add any word in the Arabic language, and it says here. So if the kid has communication disorder, his or her sound is not clear, or has no expressive language, they have expressive language in the brain, but they can't pronounce it. It's just so easy here. It's mostly for CP patient or the adult patient after surgeries, if they have no vocal cords anymore. It's so easy, and it's so easy to train to also. So if the parents or the family or the patient itself need any help, the speech therapist can help with that. And it's a really voice for the patient. And that's it for today. Thank you.
Thank you very much. Just a recognition for the speaker for the last two workshops, Dr. Ahmed Helmi. أفنان الجمال. فاطمة. And thank you all for attending our conference. We finished for the second day. Now we will have the lunch. Before that, I would like to thank you all for attendance, and I hope you enjoy it. And I promise you, next year we will have a better conference, inshallah. Thank you very much.